I would like to welcome all of you to this AIOS Endowment Lecture Award session as well as the General Award session. The talks would be done in this session, and all the awardees will be awarded in the inaugural function, which is going to happen in the evening today. And it is my pleasure to call upon the first speaker, none other than Professor Ramanjit Sihota, to deliver the AIOS LP Agarwal Endowment lecture. Ma'am is ex-head of the RP Center for Ophthalmic Sciences, Glaucoma Services, and currently consultant at Shroff Eye Center, New Delhi. And she's also revised Parsons diseases of eye. I think she actually needs no introduction. I took ophthalmology because I saw ma'am as an undergraduate student in Lady Hardinge Medical College. So thank you, ma'am, and over to you for your lecture.
Thank you very much. I think in this gathering of people who've been in ophthalmology for so many years, Professor L.P. Agarwal actually needs no introduction, but I hope for posterity and for people who haven't heard of him, he was a colossus, and his interest did seem to include primary angle closure disease. In fact, his work was quoted in Duke Elder, and that's why I thought that this was an appropriate topic to talk about. So there are many milestones as far as Professor L.P. Agarwal was concerned. I think the important ones were the fact that he founded RP Center as the apex government center for India. The National Program for Prevention of Blindness was the first in the world. He pioneered the concept of super speciality in India, made sure that faculty was sent out to specialize in different branches, and he went on to also influence WHO. So my personal interaction with him is as a disciplinarian. He would be at 7 o'clock at the door of RP Center to see who came in and who was there on time. He would come again for night rounds. And as a first semester junior resident, I was posted in his OPD, and a governor with about 4 or 5 people sort of walked in, took one look at me and said, "हमें तो Dr. L.P. Agarwal को मिलना है." So I said, "First, यहाँ हम देखेंगे, उसके बाद आप जाइएगा." So they opened the door, barged in, and Dr. L.P. looked at them and said, "आप पहले उनको दिखाएंगे, अगर वो चाहती हैं तो मैं आपको देखूंगा." So he was the kind of person who was principled. He made sure that if the people came to him with problems, he would send them off to the right super specialty person. In these two quotes, one was to say that he was one of the best postgraduates that Moorfields had seen. And as Dr. Rao over here has said, he actually wanted to place Indian ophthalmology in the highest place in the world. So coming back to angle closure disease, as I said, RP Center and India have improved the understanding of primary angle closure disease in many ways. We pioneered the measurements, the anatomy, the physiology, biochemical and histopath studies, genetic studies. We've also tried to subtype and classify angle closure disease so that it's easier to manage clinically, and studies on long-term prognosis. So Dr. Sood was one of the first who actually looked at how common primary angle closure disease was in India. And this has been replicated in LV Prasad and many other centers across India. In surveys, it was seen that primary angle closure and angle closure glaucoma were almost equal or more frequent than primary open angle disease over 40 years. We did a population-based study to say why was it that Indians were so prone to angle closure, and we found that 40% of us walked around with an anterior chamber angle of less than 20. So this was in addition to the already known anatomical factors which said axial lengths which were close to 23 or less than 23 were more likely to go into acute angle closure. In the subtypes, the acute angle closure disease obviously had the smallest eyes with the most crowded anterior chamber angles. We found it was familial, and we could actually identify the axial length of an index patient as a way in which we could identify family members who might go on to angle closure disease. In genetics, RP Center, AIMS, and the National Institute of Biomedical Genomics did a GWAS where we looked at people who had the anatomy but didn't have the glaucoma, and compared them with the glaucoma. So we were able to identify multiple SNPs which actually said why the IOP rose and also why the degeneration of the optic nerve occurred. So in pathophysiology, relative pupillary block was well known, but what we added to this was the fact that even with the Valsalva maneuver, you could end up narrowing the angle. And you can see in this small video, you can see the angle in seconds, narrowing with iridocorneal contact and then settling down again. So pathomechanisms of angle closure have been studied by L.V. Prasad by us, and we find that 70% or more are relative pupillary block, about 20% lens vault with some relative pupillary block. So if we then looked at the histopathology to see why the touch of the iris to the trabecular meshwork caused the IOP to rise, in the acute phases, we could show that there were an inflammatory response, a reactive trabecular change, and once they healed, all the spaces got blocked. We again looked at it with the scanning electron microscope, and you can see the normal trabecular meshwork openings. And then after an acute angle closure, you could see the phagocytes, the edema that was actually blocking the spaces that were seen above. And finally, when the healing took place, this caused a homogeneous deposit, and the spaces were actually completely obliterated. We also wanted to see why a touch progressed to synechia. And when we looked at aqueous changes in the primary angle closure glaucoma, we were able to show there were 16 novel proteins, and immunoglobulins were largely found in primary angle closure glaucoma. So we put it all together and said histopathology together with what we saw clinically, together with what happened in the optic nerve, and we found that primary angle closure with ocular hypertension was a stage in disease which had not been recognized earlier, and that is very important to actually treat. We also reported a few things like the pupillary rough atrophy, that we could do a Van Herrick in a much easier manner during slit lamp examination, and it was actually much more sort of correlatable with ASOCT values. Optic neuropathy was seen to be more ischemic and therefore more saucerized. Central neural changes in PACG were also found to be different from open angle glaucoma. So coming back to management, the stage of primary angle closure with ocular hypertension was something that had not been highlighted earlier, and therefore it is important to know that once the pressure starts rising, the chances, of course, of optic neuropathy also increase. So in all cases, an iridotomy is something we were taught to do, but what does the iridotomy do? It does not lower IOP, but it does decrease further pupillary block, and in the process, decrease progression. So if you actually look at this patient who has chronic angle closure disease, you see a completely closed angle, and the green line below, you can see that there's a high iridotrabecular contact. The moment you do an iridotomy, you can see the angle that has opened, and you can see the iris has fallen back. So even in angle closure glaucoma with extensive pars, if you do an iridotomy, the iris does tend to fall back, and you can do medication for these patients. PAC over time changes into ocular hypertension, and ocular hypertension, as I said, is something that needs to be treated so that this doesn't progress to the optic neuropathy. Some of the suggested target IOPs were for early, moderate, and severe defects after an iridotomy has been done, and these need to be reassessed over time. In angle closure glaucoma, we needed a much higher reduction in IOP to achieve stability. Over 10 years from RP Center, what we found was if we actually adhered to these target IOPs, the progression in primary angle closure glaucoma, which is actually otherwise a blinding disease, was only 1 to 2%. Trabeculectomies were something that people were a little afraid to do because of the shallow anterior chamber to start with, but if you use releasable sutures, again over 10 years, we found that the success of less than 15 millimeters of mercury was over 77 degrees. Phaco in PACD is something that everybody wants to do. All cataract surgeons want to do a phaco, but please remember that the EAGLE study said that there was a 1 millimeter difference between an iridotomy and phaco, and this difference was unlikely to be clinically significant. So over time, you can use phaco as a replacement from iridotomy, but do not expect it to control intraocular pressure. So just to end, I would like to say that patients in India present early. So let's take this lady presenting at 50 years. If we were to do an iridotomy and follow her up over time, what is likely to happen? In 100 patients, over 5 years, maybe 25 to 30 will develop a slightly raised pressure. If you control the pressure and everything else is taken into consideration, they should not progress. But because glaucoma doesn't work like that, use of steroids, genetics, may cause about 6 to develop a visual field defect, and we can prevent this from progressing. So to reiterate, our contributions from across India in primary angle closure disease was in understanding that there is a predisposing anatomy. There are physiological changes which we should be aware of. We know now what the trabecular changes are. We know that there are genetic differences which have been identified. As far as clinical relevance is concerned, we know that presentation in India is very different from elsewhere because we have mostly patients who do not present with pain. They have no headaches, and most of the time they have a completely closed angle when they appear. Efficacy of iridotomy and surgery was shown to be a long-term use. Finally, the clinical importance of Indian studies means that we should screen all families, use axial lens as possible for identifying family members, and iridotomy is a must and safe for all primary angle closure disease, including glaucoma. For PAC, please review annually. For PAC with ocular hypertension, reduce the IOP to less than 18. For PACG, use target IOP. And please remember that cataract surgery cannot reverse trabecular damage. Use medications as required. Acknowledgements to all my mentors, to all my colleagues. I think this is a huge team effort. Thank you.
Please come, sir.
बैठ जाएं? बैठ जाएं?
It is a pleasure to invite the next Endowment Lecture awardee, AIOS P. Namparumal Swami Endowment Lecture by none other than Dr. Subhadra Jalali, Network Director, Newborn Eye Health Alliance, Anand Bajaj Retina Institute and Child Sight Institute at Srimati Kanuri Santhama Center for Vitreoretinal Diseases, and Jasti V. Ramamma Children's Eye Care Center, LV Prasad Eye Institute, Hyderabad. And she's going to be talking to us about ROP care beyond boundaries.
A huge thanks to everyone who's allowed me to be here on this day to speak about ROP care beyond boundaries. I think to receive an award in the name of my Param Guru, my Guru's Guru, Professor Namparumal Swami, is really an exhilarating experience, and my homage to this towering personality. I might break any amount of barriers, but I'll never be as tall as him. And with his blessings and blessings of my Guru, Dr. Das, I want to just say that ROP has always broken boundaries, right from Dr. Cooney, who had to fight for 40 years to get the babies from exhibition incubators into Boston Children's Hospital and New York Children's Hospital. And within a year of these children coming to the incubators in the medical stream, we saw ROP developing in 1941. That's the first case sheet where the doctors were very surprised that are they seeing cataract, and only later they realized it was behind the lens. And then from 1940s to 1960s, 70s, there were people in Japan trying to find the cure. There were people in West trying to find why this is happening. And by the time 1990s came, the randomized control trials had already been done, and the ROP treatment with lasers became the benchmark. But where was I in those times when all this science was developing in the West? I was this tiny girl in the basket of my mother's hand, born and living in the paradise of earth, had no idea about the world, about the ROP, and had a secure life with family and culture of Kashmir. And then I jumped to PGI Chandigarh, where I had, again, no exposure to ROP. There was no ROP in PGI Chandigarh till 1989 when I left. But when I left, the world changed for me and my families because of the war and terrorism, where we had to leave in 1991. We were forced to flee, reach Hyderabad with just 2 gunny bags of books. No money, no godfathers, no language. The only thing we had was language of love, hard work, and found lovely people there of all cultures, colors, faith, Our home was vandalized, but it didn't vandalize our hearts. And here I was in 1991 when the cryo-ROP study had already shown how the ROP has to be treated, and I was right in the place where Hyderabad was getting out of its sleep of 400 years old culture and roaring to reach the sky. And this is the best setting where ROP develops, what we call as a middle income country, where there is old and new, but it's not as new as we want. And in that milieu, we set up the first city-wide ROP program anywhere in India, maybe in whole of Southeast Asia. And it's all because of the benevolence and blessings of my teachers, Professor Tracy in Michigan and Dr. Das in Hyderabad. And why we are talking about ROP in 91, you can just see here that L.B. Prasad Eye Institute database does not have any ROP till 94, 95. Few babies were coming, and by the time the institute decided that I have to go for ROP training, you can see we were seeing 12 blind babies in that year. And as soon as I came back in 98, the numbers jumped because there were a lot of IVF centers and NICUs mushrooming in our city. So what did we change? The first thing we changed was how the world was screening these babies. This is the diagram which the cryo-ROP said, and put an asterisk there, said based on insufficient data. But we had the data to say that the babies who are smaller should be screened earlier, which was completely opposite of what the West was saying. And so we gave this slogan of 30 din Roshni ke, 30 days to vision, which is what is now being followed everywhere. The second thing we changed and broke the boundary was the screening criteria. We took almost 3 years to get the paper published to say that the babies in our country are not 1500 grams 32 weeks, they are 2000 grams 34 weeks. And it just took 5 years to get that into Sheila West's book. And today that is the standard of care for all developing countries, including us. The next was, what's the outcome? The cryo-ROP study and all these studies on ROP, they said, good outcome is if the child can see 2200 or better. Come on. If the child sees 2200 or better when it was born with a pristine macula like this, they cannot get a driving license. They cannot study in a normal school without visual aids. We changed that. We said, no, our goal is not prevention of detachment and getting 200, 2200. We are going to push the boundary and say the child should get 20/50 or better vision. And that is what we worked at. So we were the first ones to say how to laser these babies. Although the cryo-ROP study was there, there was not a single paper of how to laser, what is the target, how to manage. And this is the paper which I think all students working on ROP read again and again to know how to get the best outcomes where the macula is preserved, there's no traction, there's no squint, absolutely normal 20/50 or better. And that's what we've achieved. Our babies between 86 to 90%, even though we are a tertiary care center, achieve 20/50 or better vision in a large majority of cases because we push vision, the refractions, the training. And that is when I thought that we need to have a team. I could not do ROP all alone. It's not a retinal disease, it's a team disease. And this is how we started the first hands-on program. And I got the platform of the 10 functional arms of LBP, and I'm very happy that our ROP program transcends 9 out of those 10. The only one we don't cover currently is iBank, but yes, it's converting it to a tissue bank, so we'll encroach there also. We went beyond, saying that these children can't see. We have amazing work with our vision rehab program, along with the parents, side by side, getting these children onto their work and seeing that they get the best outcome. It was after some years I realized that, the book says something, but what we see is something else. And it was, not very implicit that the ophthalmologist has any role to play in prevention, in managing these diseases. But I come from the mountains, and, the trees in the mountains tell us the story of what happened last year, what happened in drought, what happened in good rain. And the retina also tells me that story. So we started looking at the retinal vessels in more clarity. For example, this fundus photograph, it tells me that the first 6 to 8 weeks of life and 12 weeks, 40 weeks, the retina was doing absolutely okay. And it was only towards the end that the vessels have started going haywire. So something has happened there. So that is where we started looking at what are these babies born with. And we were the first ones to publish that babies are born with a retina depending on the maternal anemia and maternal nutrition. Now, nobody had said this. Everybody said ROP is a postnatal disease. Now there's more and more research happening that it is antenatally decided what the child will be born with. And if we correct maternal anemia, a lot of our problem will be reduced. And so here's one baby sent to me for treatment. This baby, on history taking, told us that everything was fine, came from very good family, but the only thing was it was not gaining weight. 2 weeks of gaining weight, everything went away. We didn't have to treat this child. We have been working on the, the biochemical pathways, the metabolomics. I'm not going to go into that, but yes, we're trying to find how else we can tackle it. We are using technology, new products, new ways of looking at these patients in the clinic with the normal adult cameras and oral fluorescence. Then we went on from the national level, working in a team, to the global level, because we realized this is a public health problem. It's not a clinical problem. And we've run programs all over the country, and I'm very happy that today, our ROP sessions are over full. We were very happy to get the guidelines, the national guidelines. I think there are very few diseases where India has national guidelines, and huge advocacy and policy change programs. But in the center, we were overwhelmed by the large number of children coming to us who were not being treated anywhere in the country, and they were going round and round. So we were the first center in India to have an own NICU with our own team of staff and skilled manpower, and today we are able to operate 900-gram baby within 24 hours of baby landing into our OPD. Don't think this will happen anywhere. We offer all types of surgical techniques, even those which seem to be redundant. I traveled to meet Dr. Hiroshi at 90 years of age to learn open sky vitrectomy. Today, we are offering all the treatments, and we're very lucky he gave all his instruments to us before he passed away. What has been the impact in 25 years? We've seen more than 100,000 babies. There's a huge impact in terms of treatments, manpower, skills, describing new entities. I don't have time to go all that, but what we do strongly perpetuate is don't leave these children unoperated. In the West, they don't operate. They say these are thysis eyes. These are not thysis eyes. They have vision potential. You can see how bad that ultrasound looks like, and just see what we can get with a 2 to 2.5 hour surgery. I close with the short 2-minute video.
Is a very
Can we have the
spiritual thing for me.
sound, please?
In that blissful space, life is really very beautiful. Maybe that gives the strength to look at disease or suffering. Grief can be overcome. My journey with retinopathy of prematurity, which is called ROP, started somewhere in 95. Slowly I started seeing that few babies were coming to my clinic who were blind. The vessels start bleeding inside the eye. They detach the retina, and after 3 or 4 months, suddenly the parents or the doctor noticed that the eye is looking white. That baby is going to be blind for life. But if we had examined this retina at 2 to 3 weeks, we could have done laser, we would have been able to save that good sight the child was born with. I got a list of all the incubators which have been set up in the city. I used to go around to more than 20 hospitals, going around the whole city, going to every nook and corner, searching these babies, making sure that they are getting treatment on time. We had only one laser machine which had to be used in the theatre, in the operating room, and it was available to me only after 8 or 9. I would put that in the boot of my car, and then we would go back to that one baby 5 miles away or 8 miles away whom we had screened during the daytime. I remember one day my mother-in-law telling my younger son, "Your mom is coming so late. Why don't you call her and tell her to come home early?" My mother-in-law was surprised that my 7-year-old boy is telling her, "Granny, what do you want? You know, mom is repairing the eye of a baby. Do you want that baby to be blind?" We were making our city blind free. And then something changed in 2007. So many babies were dying. So very rapidly, newborn centers started mushrooming all over the place. All of us retina surgeons in the country were suddenly overwhelmed. A lot of blind babies coming to us. So the government, with the help of the trust, set up a national task. But today we are very proud that we have come up with the national guidelines which has been published. They are fighters, these premature babies. When they are born, they look very fragile. You just try to catch the hand of that baby. It will just grasp your hand. I want to live. I don't want to die. They grow into amazing human beings. There can be no more reward for a doctor than to see this happening in their lifetime.
Thank you.
Dancing is a very spiritual thing for me.
Now I invite our next AISP Nimpurul Swami Endowment Lecture Awardee, none other than mentor Dr. Rathinam Sivakumar from Aravinda Hospital. She is the principal and head of uveitis services at Aravinda Hospital, Madurai, and she has done her PhD on leptospiral uveitis in 2005, and she is the member of the National Academy of Medical Sciences. Over to you, madam.
Thank you. Good morning, everyone. It is a great honor to be here with you. I sincerely thank Scientific Committee as well as Scientific Committee members and AIOS for giving me this great opportunity, specifically to talk on Nambarman Swami Sir Endowment Award, because I have worked under him for 40 years. Whatever I have listed there, starting from punctuality, responsibility, to all those things, every day I have seen him, and lifelong learning. And that is, yeah, thank you. Lifelong learning, all these things, I have seen him day in, day out. And more importantly, it's not moving. The next slide is not moving. Yeah, more importantly, it is the empathy and the kindness he showed towards his patients as well as his colleagues and students. That is what about the whole lecture is. You will be surprised, uveitis is a rare disease and it came as an epidemic some 33 years back. You will not believe, we had 250 patients in 3 months with no diagnosis. It was a very unique one, and I was working very hard for 6 months to 1 year to know what it was, and it had some hint that it is likely to be leptospirosis. But the textbooks were not mentioning anything about leptospiral uveitis, leave alone the general books, ophthalmic books or uveitis books were not talking about leptospiral uveitis. So many people were laughing at me and they were telling that I am very biased with the diagnosis, particular diagnosis which is not there in the textbook. And Dr. Nam told in one of the grand rounds, she is very confident, so let her prove and we will wait and give her some time whether it is leptospirosis or not. His words really, it was really a support for me to work on leptospirosis. So the whole talk is how did we find out the cause of epidemic fever and uveitis, and how Dr. Nam helped me through this. What happened is, in 1992 November, we had a heavy rains and monsoon rains in Madurai, and we had acute pan-uveitis patients, young men every day, few men every day, and it is acute pan-uveitis with hypopion. So if you have the differential diagnosis, pan-uveitis with hypopion is Behçet's, which cannot come as epidemic at all, which is very rare. And pan-uveitis with hypopion, endogenous endophthalmitis is another possibility. It cannot come as epidemic. So this is not fitting with any known entity. And the most important thing was they gave history of fever 1 or 3 months before the attack of uveitis. And they were coming from flooded parts of Madurai. So we came to the conclusion that it should be a waterborne disease, it should be a febrile illness that causes uveitis. But nowadays we have Google or AI, you just put all these things, I checked it, it just shows leptospirosis. But this is 1992, where we did not have cell phone, we did not have computer, we did not have PubMed or Google. So you have to find out from the textbook only, and unfortunately it is not showing anything. When we see the systemic textbooks, they say fevers, but epidemic fever in a tropical country is not covered in tropical textbooks. So that is a little thing, little different, and we cannot get Davidson or great Western books talking about a tropical epidemic fever. So we were clueless at this point of time. Then what happened is, one good thing, I was collecting serum from every patient. The moment I realized that there is a rise in number, I collected blood serum from every patient. I did not have even a refrigerator. I did not have research lab. I did not have funds. I am not a research scientist also, but I collected the serum. So I put it in the store. There is a store and a refrigerator in Aravinda Hospital. We collected, and it was 250 samples by the time we realized that we are going to do something with them. So I had 1 month, 1 year old baby, feeding baby. But after hours, I used to go to the private practitioners and ask, wow, do we have a epidemic fever going on in the community? And they told, you don't know the reason, ma'am. It is a monsoon season, so it's a seasonal fever. So the same answer was given by Government Rajaji Hospital. I went to Government Rajaji Hospital asking for a cause. Is there any epidemic fever going on? And they also told it is seasonal fever. And that is not an answer. We need a etiological diagnosis. So I thought maybe we go to the scholars. So I went to Madurai Kamaraj University. I was meeting the scientist there. And I was asking, is there any epidemic fever going on in Madurai? And they were laughing at me. They told, you are a doctor, you should diagnose, and we should do research on that. You are asking us to diagnose. It absolutely right. So I returned empty-handed, and then I went to Madurai Corporation asking whether they have any list of epidemic and endemic diseases in Madurai, and they were not entertaining me because it will become a news, and that is a headache for them. So then I went to microbiology department to know whether any bacteria they know which can cause fever. Luckily, I met one person, MSc microbiologist. He is not a doctor. He was doing a PhD in syphilis, yes, spirochete. So he told, I am working on a syphilis spirochete, and I know another spirochete, leptospirosis, and that can cause fever, but I do not know what is uveitis. Obviously, he is a MSc PhD, he cannot know uveitis. But at least I heard the word leptospirosis. Then again I went to Madurai Kamaraj University asking, you know that we cannot put it in computer and see. So I went to Kamaraj University and asking who is working on leptospirosis. And there was one Professor Ratnam, veterinary surgeon working on leptospirosis. I went to him and he proved that it is leptospirosis and it is a waterborne disease coming from animal. And unlike syphilis, this can live in the mud or water 1 month without any support. So these people, when they work in the paddy field without any slippers, they can get fever, and 60% of them get better from fever, whereas the 30% of them get into hepatorenal failure or pulmonary hemorrhage or cardiac failure. 4% of them die without knowing the cause. Neglected tropical disease, they die, they do not even know that they died of a disease because of their occupation. So Dr. Nambarmal Swami sir sent me to USA as well as Europe and Australia, where there are world reference labs, and so we started having multiple collaborators, and all these 3 labs confirmed the diagnosis of leptospira uveitis, and we came out with the second publication in American Journal of Ophthalmology. But there are several questions unanswered. Why I am only talking about, for past 10 years I am talking about leptospirosis, but no systemic people are talking and no veterinary people are talking, and we had series of questions to answer. So we started several research around this leptospirosis, and we set up our own laboratory in Aravinda Hospital with the help of Netherlands Tropical Hospital, and we proved that all our farmers get fever only because of leptospirosis. So systemically, people have leptospirosis, and veterinary science, we collected goats, cattle, and in butcher's place, we collected the kidney and urine, and we proved that the animal also have leptospirosis. So with the reference lab, over 15 years, the sensitivity of the kit, sensitivity of the mat reduced because we were continuously subculturing. So we had to have another alternate pathway. So what we did is, we wanted to have a diagnostic clinical rule. So we compared the signs of leptospira uveitis with the non-leptospira uveitis patients, and we ran the multiple logistic regression. We compared 800 leptospira uveitis patients and non-leptospira 4,000 patients, and we came out with the major predictors and minor predictors, and we published yearly. Then later, we found cataract absorption in these patients, and we wanted to do histopathological study. This was leptocataract with balloon degeneration. This was senile cataract with irregular fibers. And then we did a proteomic study, and we found that antigen mimicry is there. And we educated these people, but they are not able to change. So we did a KIP study, and the knowledge was poor both in public and medical students. Then to raise the awareness, we published series of papers in Indian journals, and with these things, we answered all the questions. Now, many textbook, ophthalmic textbook, have a chapter on leptosphere uveitis. That was our achievement. That is because of this great man. Thank you.
Thank you, ma'am. Next, in this series of very prestigious endowment awards by the All India Ophthalmological Society Scientific Committee, we have AIOS, Dr. G.N. Rao Endowment Lecture. We are very honored to have Dr. G.N. Rao, sir, amongst us, a living legend. Thank you, sir, for being here personally. And this year, this award goes to none other than Dr. Radhika Tandon, ma'am, who is the chief and the professor of ophthalmology at the prestigious Dr. R.P. Center of Ophthalmic Sciences, AIMS, New Delhi. She's going to talk to us about tackling corneal disorders, a personal story of innovations and new approaches. Over to you, ma'am. Thank you so much.
Good morning, everybody. I'm most grateful to the AIOS Scientific Committee for honoring me with this endowment lecture. So Dr. Rao, of course, is an epitome of leadership and extreme perfection in life, as well as clinical ophthalmology. And I'm very fortunate to be having an opportunity to be giving a lecture in his name. As far as our RP Center is concerned, we're always happy that Dr. Rao has been an alumnus of RP Center, and there are many things that he has taken away from the center and given back. And recently, when he was celebrating his 80th birthday, was it, sir? 80th birthday. It's really difficult to imagine that sir is actually 80. You know, 80 is the new 60. No, the thing is, 80 is the new 60, I must say, and it's, you know, you have to think back. So he'd come to the center, and it was beautiful to have the interaction with all the young faculty as well as the students. And I must say there are a few things that he said that day which got many of the young residents to rethink about how they viewed their lives and their perspective on ophthalmology and how they could contribute to the country. There's a lot that I can say, but looking at a few aspects, one thing what Dr. Rao has epitomized in his career is that he's been passionate about cornea, something which has stood the test of time, and he's also given his entire strength of his abilities to eye banking. But in addition to that, he's had a major role in academic education leadership, not only institution building, but also nation building. So he's had multifaceted roles and responsibilities. From my side also, I've had a few contributions in different fields, and sometimes one feels one should focus on one thing, but on the other hand, you focus on what you've got. So it may seem a little bit you know, that one is dabbling in many things, but I say that the way life takes you, you just work with what you've got, and you just work hard and make a difference in whatever you're doing. Now regarding, one tended to always keep a small picture, like what am I doing, what am I teaching, what is happening around me. But Dr. Rao has taught us to think big, and one has to think nationally, and one has to think globally. And a little thing, it's not very easy to galvanize everybody and all stakeholders, and I've been pushing for this, that we should all work together to the concept of miracle by dream. Now, what is miracle? It is a mega initiative for the eradication of corneal blindness in India eventually. And it is actually eradication of the avoidable corneal blindness. And this is actually possible. And how can we do it? One is, of course, by working together and having an integrated approach, and by dream. So digitization. As we stand in India today, we do have a lot of infrastructure that we can galvanize. We have to re-energize people. We have to educate, advocate, and also do multitasking. Now, talking about one's little contribution every step you do, it may not be changing the big picture, but it's adding one drop to the ocean. So at the same time, one must not forget that what we do every day, we must do it with perfection. So each and every cornea that we are transplanting, even if it is one cornea or two corneas, that one person and second person is getting their sight. So we must maintain the safety and standards. Well, patient should not be getting infection due to the corneal transplant per se. So one has to make sure that you have to upgrade and modernization of eye banking. We've always been chasing numbers that yes, we want to increase more, we want to have more, and we have so many blind. That's fine, but in a way it's very disheartening because we're never reaching that stage of reaching those big numbers. So at least let's be happy with what we do today. So I would encourage every eye bank to make sure that every cornea which comes into their fridge is used, even if it's not optically utilizable, but look at a way of making sure it's used. So that's a simple thing. So upgradation and modernization, and also think about it, why is that cornea not utilizable? So each eye bank, see, we can't do everything, but we could encourage people working with us to think. So whether it is the grief counselor, whether it is the technician, everybody needs to just think about it, that why has that cornea come into my fridge which is not utilizable and which the surgeon is not willing to transplant. Then factors we also looked at, so we're, as I said, looking at various aspects simultaneously. People are also very disheartened that people are not wanting to donate. So we are here as healthcare professionals. For us, it's very easy, but you have to think about the mindset of the people. You cannot be judgmental. You must understand what is their hesitation. And honestly, there is a lot of hesitation among a lot of people, and we cannot be judgmental that they're wrong, they have these concepts, but still we can see that the people who are willing to donate, why don't we increase that? So we looked at the factors, and one trouble one finds, or one good part one finds, is that when you have a post-mortem or an autopsy case, the family is oriented to the fact that there is going to be a procedure done on the person who's passed away. So those are the donors where we should at least try to make them feel satisfied that the corneas are going to be donated. The other thing is that they are young people. They're often 30, 40-year-old, and it's very soothing to the family to know that the person has died, but the cornea can be transplanted. The other thing is also we had to do a little mindset change, because there was a traditional concept that the whole globe would be dipped in betadine, and in a country like ours, we can't do in situ because there's more risk of infection, and we don't have the technical skills because removing the cornea in situ is a part of the surgery. So this I will give full credit to Dr. G.N. Rao, Dr. Usha Gopinathan, and the entire LV Prasad team, that they were they took the inspiration from the US Eye Bank. So everything you do contributes in some way or the other, and using the concept of the US eye banks, that you can do in situ excision in a tropical country with their help. So even in our government setup, we were able to transfer, but it was very difficult to directly transfer this concept. So we did a thesis by Dr. Vishal Jhanji, whom many of you would know. He's now world famous. So Vishal Jhanji's thesis was to prove that yes, whole globe enucleation can be done safely. Similarly, one donor cornea for 3 recipients, again a concept that we use that does require a lot of coordination, but yes, it can be done. And then the other thing we had is, this is from the time of Dr. Madan Mohan, that he has said that we can take corneas more than 6 hours after death if the body is refrigerated. This is a practice which is happening again in the West, and there's a lot of hesitation among surgeons that even now in my own institute, many of the people still feel, oh, 12 hours, 13 hours. But if we have shown with the help of Dr. Dhaval Patel's thesis that death to preservation time, it is a factor, but you need to look at all the loopholes. So we looked at dead preservation time, endocellular cell density, and refrigeration. So if the body is refrigerated within 6 hours, you can extend the death preservation time. So don't discard those corneas. Don't say they're not utilizable. Do take those corneas and do transplant them as suitable. Now coming to another aspect about going into the public, going into the periphery. Now one thing is we realize that you cannot control everything from one institute, and it is an initiative from the government of Punjab which taught us, if you have a good push from the government and if it is a centrally controlled plan, it can work magic. And fortunately, the Health Secretary of Punjab, Vinnie Mahajan, she was very motivated, and a good IAS officer can open doors and work wonders. So she said that, no, I want to say that it will make it Punjab corneal blindness backlog free. She actually wanted to make it corneal blindness free. She asked me to be as an expert. I said, said we can't do that, but let's have some achievable targets. The key thing is at that time in Punjab, what was happening is under Thota, an iBank had to pay, I think 1 lakh rupees was the charge for an application for a Thota license, because in their mindset it was felt that this is a kind of a situation where there is a lot of money involved. So this was, we had to explain that it is not so, and they were able, in the rest of the country it is 5,000 rupees, but in Punjab government they changed it from 1 lakh to 10,000. But I would appreciate it that at least the Punjab government had given it some thought. They had not just blindly put in Thota as everybody else had done. They had thought about it. And then the target was, so there was a joint effort, policy and regulations, many, so like just with a phone call, she was able to speak to the concerned department. They were able to correct the law, they were able to correct the rules, they were able to adapt, and then capacity building. So just to say that monitoring, and then she said one more thing, what's happening afterwards? So it was very important to build what is happening after the transplant. We need to show, is the blindness really going to get cured? And so she made sure every center would give its report, what is the 1-year outcome, what is the status report, and it was beautiful to see the meetings and how everybody would respond. So this model can work, but you do require the government to be on board. There were these WhatsApp groups which were created to make sure that every cornea transplanted and what was the outcome at time. Quickly over RPC and AIMS, we have our director, Dr. Tichal was the chief of the center. I was chairperson with Namrata and Tushar. This is the way the National Eye Bank was functioning. And we also tried to look at the organ donations. So when we found out that organ donations, each and every cornea from a multi-organ donor is actually 100% transplantable. But we suddenly found that there were newspaper reports coming that kidneys were donated, liver was donated, but eyes were not donated. And I asked Dr. Deepak Agarwal, who is from the Trauma Center Neurosurgery, and he himself was not aware of many of the hindrances. He said the family would say, we're going back to the village, and they will see that the eyes have been removed. They don't mind whatever has been taken from within the body, and he himself was not have the conviction to convince them that there will be no external disfigurement. And this is a very highly qualified neurosurgeon in our own hospital. So then we quickly sent pictures before, after, and explained. And we looked at the donor characteristics and graft outcomes of corneal transplant from multi-organ donors. This was a thesis of Aishwarya Rathod. And we found that this is an area that we should not let go, because they're 100% transplantable. And again, even if you get that one donor, 2 patients are getting transplanted, and we cannot afford to lose even one. And finally, we will look at bioengineering alternatives in the future to see if we can have a 3D printed cornea. Thank you so much. Thank you. Thank you.
Thank you, ma'am. So next Endowment awardee, Dr. Gulapalli N. Rao Endowment awardee lecture, My Journey in Keratoplasty by Dr. Sujata Mohan. She is the Executive Medical Director of Rajan Eye Care Hospital Private Limited and Director of the Rotary Rajan Eye Care, Rajan Eye Bank. Welcome, Dr. Sujata, madam.
Good morning, everybody. It's a privilege and honor to deliver a lecture named after Dr. Gulapalli N. Rao, a visionary who transformed the landscape of eye care through innovation, compassion, and excellence. His work reminds us that world-class science and compassionate care can transform millions of lives. His legacy continues to inspire us to combine science, service, and compassion in restoring sight. The first time I saw Dr. G.N. Rao was when I was a student at Shankar Nethralaya, and he had come to visit Dr. SSB when he was still in the US, and he just came to look around and see whether it's possible to develop a similar center of excellence in cornea. I think from then on, I think the story, we all know the story, how L.V. Prasad Institute has flourished. And I think vicariously I've been observing him, though I wanted to do a fellowship in the 90s, early 90s. They said the waiting period of about 4 years, so I couldn't do it. And I never had the opportunity also to do any type of cornea fellowship. But he has been a great source of inspiration for me, and all his teachers have indirectly or directly have taught me in so many ways. I think I'll be failing in my duty if I don't acknowledge what I have learned from Dr. Prema Padmanabhan and Dr. Manju Kulkarni, who shaped my interest in cornea, in corneal surgery. And because of them, and that they were the only people I had observed in my entire career, because I had not done any fellowship. And I started doing my corneal transplant surgeries in 1996 once we started opening we opened the eye bank. And from then on, it was no looking back. My passion in cornea still continues. And most importantly, I would like to also acknowledge Dr. Dua, because I went and visited him somewhere in the early 2000s. But by then, lamellar keratoplasty had not started, but he taught me a lot, even like how to remove sutures post-keratoplasty, how to recognize a graft rejection. So small things like this did make my practice easy. So I'm just going to go through my own interest in keratoplasty. So we all know that penetrating keratoplasty was the treatment of choice till we understood that lamellar keratoplasty could be done in certain situations, particularly because of the complications associated with PK, like loose sutures, vascularization, high astigmatism, wound dehiscence, and graft rejection. So why not use a lamellar architecture to replace affected anterior and posterior layers of the cornea? But still, in spite of the fact that lamellar keratoplasty has taken impetus, still we do PK in some situations, like where patients have adherent leukomas, corneal opacities, and in patients with corneal abscess, such as you see in this. And these patients will still, you need to learn the skill of doing a penetrating keratoplasty. So this is a case, again, a patient who was an 85-year-old patient, extremely fragile patient. So we decided to go in and do a penetrating keratoplasty. So there's nothing wrong in doing a keratoplasty, because we have been doing keratoplasty for millions of years and have very good results. But you have to follow all the protocols and just make sure that whatever you're doing to the patient has to be matched to his ability and his age, and so other factors like that, so you get the best possible results. So then came lamellar keratoplasty somewhere in the early 2000, and so again I was left in a lurch. Should I go in for a lamellar keratoplasty? I mean, I've got excellent results with PK, but you know, when the world moves, you have to move along with them. So we had no choice. So these are some of the indications for lamellar keratoplasty, but I think the most common indication we do is keratoconus. And surprisingly, Shankar Nethralaya had a course on DALC somewhere in 2004, and so I started my first case of DALC even before my endothelial keratoplasty. I started DALC somewhere in 2004, and so the technique at that time was we used to give a big bubble was the most important thing that we learned. And though it was technically challenging, there were a lot of pitfalls in DALC. And this is one of my cases of advanced keratoconus, where I like to see the level of the cone. So I use a fluorescein, and after that I measure the cone. So sometimes the cone may be large, very large, it can even go up to the limbus. And I always use a Fleringer ring, so that in case we land up with a perforation, I don't have any problems like expulsive hemorrhage, because most of these patients are very young patients. And this is, I do a very deep lamellar dissection and use a 30-gauge needle to form the big bubble. So there are different techniques which we can use for forming the big bubble. And of course, there are techniques where you can do just a manual dissection itself if you're not able to achieve a big bubble. So it's no longer difficult to do a DALC, because you don't have to worry. It's always important to preserve the patient's own endothelium. So this is a technique where it's a 4-quadrant technique. After achieving the big bubble is slashed, and 4 quadrants are made in the superficial cornea. The Descemet's membrane is exposed. Here again, when if the Duas layer is present, the chance of perforation becomes much less. And if the Duas layer is not there, such as in where the big bubble is completely involving all the layers, Then in this case, you have to be extremely careful, particularly while doing the dissection very close. So this has been a big learning task for me, and over a period of years, I think I have perfected it. And this method I follow routinely. I use only a 30 gauge needle, though there are several methods of forming the big bubble. And I still do manual DALC in patients where, such as in scars where the big bubble doesn't form. And once you've exposed the descenates, the quality of vision becomes much better, and then you can replace it either with a slightly oversized graft or same size graft, depending upon what position the patient is in, what is the indication the patient has. So this is a pre and post-op of some of my cases. So the perforation is again another thing that we have to think whether you're going to convert the patient into a PK, a full thickness PK, because you need to have a good graft on hand. And if it is a very small or medium perforation, you can still complete the LK. But in case of large perforations, you might have to go for full thickness penetrating keratoplasty. So these are some of the complications that we come across. And in this case, I think I'd like to acknowledge the textbook by Dr. Rasik Vajpayee on lamellar keratoplasty, which helped me to learn a lot. So in those days, since we didn't have the YouTube or any other source material, so only these textbooks, they helped me, at least for me, because I don't have a proper fellowship, it helped me along and helped me to handle these postoperative complications. And of course, attending a lot of lectures also. So this lamellar keratoplasty can also be done in patients who have a rheumatoid melt or patients who have infections, where you can do a small sized graft and then you include some clear area of the non-infected area of the cornea and do a lamellar keratoplasty. And basically this is a tectonic procedure, and just to maintain the globe and prevent any perforation and completely losing, making the patient blind. And as an initial procedure, these the lamellar keratoplasty can be done, and then it can be followed up with a proper optical penetrating or penetrating or DALC procedure. So the new advances in LK actually helped me a lot when I switched over from PK to DSEC. And for quite a long time, I was using the ALTK machine. That is after the first few years once the ALTK machine was introduced. I'm telling you this because there's a story behind it. These are the high-risk patients who are going to have problems. So now the different types of posterior lamellar keratoplasty we're all aware of. And why should we completely shift to this was the reason we all know, like high astigmatism, rejection, early rehabilitation. So all these things definitely make a lot of sense in converting. And it requires expertise. Again, it needs a lot of wet lab practice, good donor endothelium, and risk of perforation has to be anticipated. And the most common indication that we come across for endothelial keratoplasty is Fuchs endothelial dystrophy, pseudophakic or aphakic bullous keratopathy. So these are some of my patients who have undergone endothelial keratoplasty. This is a patient with cataract with Fuchs endothelial dystrophy. So this, at this point, I want to just thank Dr. Manju Kulkarni, who brought her first case of DSEC to me, and she told me, I'll do the phaco, you do the DSEC. And till the time, I had not done any lamellar keratoplasty. I had bought an antechamber maintainer when I had gone to ACRS. So we decided to use it. And the case went off very well, and the patient has been following up with me for the past 20 years. He goes to both of us, and the results are fantastic. So that is the greatest advantage in having a teacher who helps us, who actually motivates us. So from then, my DSEC journey began. These are some of my post-op patients, post-DSEC. So this is the last case I'm going to show you, is a phaco DMEC. Again, this was again an accident how I started my DMEC in 2018. So here you can see that I'm injecting the DMEC graft. It's important to make sure that the S mark is oriented properly. So the reason why I started was that I was telling you about the ALTK machine. And the ALTK machine, what it had done is, in that case, it went through and through, leaving only the decimates behind. So now the choice was whether I'm going to continue, I'm going to shift to a PK, or am I going to do, what am I going to do with that graft? So I decided, okay, let me try doing a DMEC in this case, because it's going to be easier to strip, because half of the cornea is anyway intact. So I did that, and that was a one-eyed patient, and I have a 6-year follow-up, more than that, 2018, so about 8 years follow-up with her, and that's how my DMEC journey began. And I'm not looking back, because I know lamellar corneal surgeries have become a standard of care. So these are some of the statistics in the US which shows that definitely there's a shift towards lamellar keratoplasty, as you can see in the Indian scenario as well. So we are looking at a case where we are coming to tissue engineering, where endothelial dysfunction can be medically treated with rho kinase inhibitors, where they can increase cell proliferation, increase cell migration, and reduce apoptosis. So this is some of the studies which have been given by the Japanese. And now the future of keratoplasty has changed from PK to DSEC to DMEC and DSO. And the journey of keratoplasty has evolved from replacing cornea to preserving it, and soon perhaps to regenerating it. One day, the greatest achievement of keratoplasty may be that we made it unnecessary. Thank you. Once again, my thanks to the AIOS organizing committee, the scientific committee, and Dr. Namrata Sharma for giving me this wonderful opportunity. Thank you.
Thank you, ma'am, for that wonderful lecture. Now I have the privilege of inviting Dr. Harsha Bhattacharjee, sir, and he's going to deliver AIOS Daljit Singh Endowment lecture on long-term biostability of intraocular lenses, insights from retrieval analysis. Dr. Harsha Bhattacharjee needs no introduction. He is founder and president of Shri Shankar Dev Netralaya at Guwahati. Dr. Harsha, sir.
Good morning. At the outset, I am thankful to the scientific committee of AIOS for selecting me for this award, but I know that I am not a fit candidate for this. So long we were listening about mostly the clinical aspect. Now I am going to say something which is the laboratory-based study, and we know that the Dr. Daljit Singh, he does not require any sort of introduction. To me, he was a rising sun, and when the sun rises, it gives benefit to all. He was an innovator, and he introduced the intraocular lens implantation in the eyes of Indian eyes, and make a revolutionary change. He discovered the iris glow lens also. So I felt that something I had to speak on the intraocular lens biomaterial, and that will be the greatest honor that I can offer to him. So we had a series of investigation, and the presentation will be a compilation of the investigation, and I dedicate everything to this great Indian ophthalmologist. Now we know that the optical qualities of polymer are determined by its ultrastructural character. There are several ultrastructural characters: are the cross-linking, the surface smoothness, the bulk material transparency, visible spectrum transparency, etc. Now, regarding the polymer, I like to say the polymer unit consists of monomer. These monomers are basic element are there, and these are bond with each other by single, double, or triple bond. Now, when the monomer unites with each other, it calls polymer chain, and the polymer chain, when it comes cross-linked, it gives the polymer material a three-dimensional structure. Now, material analysis means we can find what is the basic element, how they are bonded with each other, how the chain forms, and how the chains are cross-linked. So entire thing we can find out by the material characterization study, and these are basically a hierarchical investigation. Now, what we have done, we have done a multi-modal hierarchy analysis. A strict protocol is there. Scanning electron microscopy, FESM, field emission scanning electron microscopy, transmission electron microscopy, energy dispersive spectroscopy, UV spectroscopy, Raman spectroscopy, and IR spectroscopy. All these investigations were done, and these are the hierarchical model for material analysis. Now, the selection criteria was very much strict, and all the confounding factors were eliminated to exclude biological variable and isolate material effects. The analytes were retrieved hydrophobic IOLs from healthy individuals without any comorbid ocular or systemic disease, and intraocular exposure time equal or more than 12 years. Now, why I have done this study? Because our institution is located in one deadlock condition of the country. Now, many people, when they are about young 60 years age, they get operated elsewhere in the country or in our place also. Then along with the age, when their resources go down, they cannot travel outside, they remain locally, and we go on seeing these cases 10 years, 15 years, 20 years after surgery. And many of the intraocular lens showing their changes. So these are our patients which are in our follow-up since maybe 30 years, and some of them I am seeing them more than 40 years of age also. So it is basically a nanoscale finding in the intraocular lens with subtle optical haze with materialized maintained fundus visibility. So a group of patients are there who have mild optical haze of the intraocular lens, but the fundus is visible. Now, what is the nanoscale finding of these cases? Now, this study shows the surface changes, and the middle picture shows the changes in the content of the intraocular lens. Here you can see the clinical picture. It was dislocated following an injury. Now, this changes why it happens in comparison to the control. This is a control specimen, it is homogeneous. This occurs due to the unzipping action in the polymer. Now, what is this unzipping action? Then monomers are bound. When they are form a chain, the chains are cross-linked. The cross-linking is just like a zip. Now, unzipping occurs. We can find out at what level the unzipping has occurred. It is a random unzipping or it is a continuous unzipping. The second sample that we have studied, we have seen that the surface cracks has developed and the intraocular lens was a bit hazy. This is the explanted specimen, and you can see the haziness in the center part of the and the peripheral part, which is under cover of the capsular bag. Rim, it was not affected. The surface cracks are there in higher magnification, and the control specimen of the same MIG, it was homogeneous. The third group of findings that we have found, that this is one of the intraocular lens, it is haziness, and it was explanted because his vision was a bit compromised. Then we can see on the surface the conglomerated microstructure, and in the higher magnification, and the FESM, it shows the nanoparticles deposit over the surface of the intraocular material. And when we have examined with the energy dispersive spectroscopy, then it says a non-calcium deposit over the surface. These are indicating that there may be some manufacturing defect, or from the packing it has come into the surface. In a long term, it is manifested in this manner. The sample 3 shows the surface erosion. So by this 3 study, we have seen that the 3 types of changes are possible when intraocular lens inside the eye for a long term on the surface as well as in the context. Now, energy dispersive spectroscopy shows that the other than calcium deposit, and I have explained what is the reason. Now, what happens in the molecular level? What is the molecular level information about the chemical bond? I have shown the structure. Now, what bond happens? Now, this is the Raman spectroscopy. This will give the idea. This has given an insight how it is happening. Now, here this spike, shows that there is monomer conversion. In all this specimen, the intraocular lens material has undergo a monomer conversion. The other spike shows at 200 or 400 millimeter, 400 reciprocal centimeter tracing we have done. Others shows that hydrolysis, oxidative degradation, and microstructural heterogeneity of the intraocular lens. And these are the evidence that along with the time, like a human lens, the lens ages. The infrared spectroscopic study of this some other sample, it shows that oxidation, chain session, cross-link alteration that proves that along with the time, the ultrastructure change of the intraocular lens occurs. This is the first study we have recorded that hydrophobic intraocular lens also can be opacified, and that is because of the deposition of the calcium. So long the concept was there, the hydrophilic lens get opacified by calcium deposit, but this is the first record that hydrophobic material also can get opaque due to the or become hazy due to the calcium deposit. Now, the EDX finding has confirmed that these materials deposit on the surface of the IOL are nothing but the calcium. Now, the optical performance of the implanted IOL which are transparent, we believe or clinically we see that the lenses are transparent, but whether these lenses are really transparent or not, and how much the light they transmit when these intraocular lenses are in vivo. This sort of specimen we have studied by UVB spectrophotometry. That photometry determines what is the transmission character of the intraocular lens. The manufacturer claimed that transparency is very good, it is like near normal, but probably it is not so. Now, this UV visible spectroscopic finding, you see this is the top graph. The top graph is the transmission of a intraocular lens which has never been used and which contains yellow chromophore. If you compare the transmission, it will see that there is 50% decay of the transmission and 100% cases could not block the UV transmission. So this is a very important finding. Say along with the time, the intraocular lens transmission declines. Now, if you compare the transmission of the intraocular lens after 10 years or 12 years of implantation, this intraocular lens ages and it is equivalent to transmission pattern of a human crystalline lens which are from a person of 60 years of age more. That means we require further better quality of IOL so the transmission pattern should not be compromised along with the time. Now, why these changes happen? Because on the surface, in the normal looking lens, there are deposits also. It has been confirmed by the UV visible spectroscopy. So the transparent IOL, actually it is not a transparent IOL. It contains some surface deposit. Now, if you consider the Lorentz equation, our value was more than 0.36%, and it indicates that these are the biomaterial change of the intraocular lens material. Now, polymer characteristic found in this study detected and proved that instability, aging, and decline of optical quality in long-term in vivo IOL. So, in summary, there is loss of polymer homogeneity, loss of surface smoothness, loss of bulk material transparency, and there is a reduction of the light transmission when the intraocular lens are in position for a longer period of time. These are due to the ultrastructural change of the material. Now, there are some limitations of our investigation. The same sets of investigation cannot be repeated in all the specimen because some preparation destroys the specimen. So we have to compare the two different specimens. But until unless the same investigation done in all the materials, it cannot be said with 100% surety. This investigation document the polymer material change, and all molecular data on commercially available IOL materials are not publicly available for comparison. However, relative to control, the findings indicate long-term polymaker degeneration. If the company consider to publish all the data, then we can examine and find out what will be the long-term stability of the intraocular lens. And that is their confidentiality, but the company can come out for human benefit to provide this data in public domain. Over the period of time, the light transmission across clinically transparent implanted IOL declines. That is something very serious to me. Now, behavior change of IOL appears to be at random. Why this random occurs? In 2025, there is a publication, it gives some highlight. It is the result of interaction between biomaterial and host immune response, the capsular biomechanics, surgical factors, and ocular harsh dynamic environment. So we require an ideal IOL biomaterial with proven long-term physiochemical stability to reduce the risk of IOL exchange in the current trend of increasing life expectancy. The people are living more and more longer after IOL. So if they require a second exchange, it will be something very serious. So we require a Raman spectroscopy based type of such instrument to find out, because it is a non-invasive technique, to find out exactly the IOL status. And one prototype has already been there in the literature, and our next research will be to develop an instrument to find out the IOL material status inside the eye in the living condition. So with that, I conclude. And medical advances is the reciprocal of clinical medicine, scientific inquiry, and industrial innovation. So when we all together will work, we can give better service. For your information, in IIT Guwahati, with the about 15,000 crore investment has been done to find out to set a laboratory where the clinician as well as the scientists will work together. These are my acknowledgement who have helped to conduct this study, and I'm thankful to all. Thank you for patience hearing.
Thank you, Dr. Bhattacharjee, for this enlightening lecture. It is an honor and privilege for us to have Dr. Giridhan Anantharaman with here. He is an institute builder, he's a leader, he's a mentor, and he has uplifted eye care in Kerala. He's the founder, director of, and senior vitreoretinal surgeon at Giridhar Eye Institute, Cochin, Kerala, and also the managing trustee of SSM Eye Research Foundation and Swarnam Eye Bank, and it's a not-for-profit community initiative of Giridhar Eye Institute. May I invite you, sir, to render the SS Badrinath Endowment Lecture on recent developments in macular telangiectasia type 2. Thank you so much.
Thank you, Fairuz, for that introduction. I thank the All India Ophthalmological Society for having conferred on me this prestigious endowment award. I'm truly humbled, and it's one of the most memorable days in my long, more than 4 decades of my long career. The topic that I chose to talk on today is on macular telangiectasia, a disease on which me and my team have been working for the last more than 10 years, and a disease which we have spoken very less in retina meetings, a disease which is often misdiagnosed, a disease which is often missed in early stages of the disease. So my presentation is basically a background on MACTIL, what is the current understanding on multimodal imaging, the new recent classification that was published a few months ago, which I feel is a landmark as far as understanding this disease is concerned, some of the important biomarkers in OCT that predict progression and with which probably we can identify biomarkers which can be identified for future treatment and future directions as far as disease is concerned. So the disease was first described by none other than Donald Gass. He's the father of macular diseases, way back in 1982. And he used color photography and fundus fluorescein angiography. And in fundus fluorescein angiography, he found these parafoveal telangiectated vessels. And that's why he gave this name as idiopathic juxtafoveal retinal telangiectasis. Subsequently, a couple of years ago, he came out with a classification. And probably even today in clinical practice, many ophthalmologists use this 5-stage classification, which probably describes to a certain extent the natural cause of the disease. The hallmark of this disease is the loss of retinal transparency. That's because of loss of macular pigment and Muller cell degeneration. So these are the two important pathological changes that we see in this disease in the very early stages. The disease is very slow in progression. Our work in macular telangiectasia started about 13 years ago, where we decided to document these cases with multimodal imaging, and today we have a database of about 762 patients, of which nearly 30% of the patients have more than 5 years of follow-up. We created a device by which these patients are called on a yearly basis so that we are able to get a good natural follow-up of these cases and the natural progression of this disease. Although the disease is most common after the age of 60 years, very rarely do we see this disease at a very early stage. And we had reported a case at the age of 28 years in a patient with diabetes with bilateral established macular telangiectasia. Our understanding of this disease has improved in the last 10 years thanks to multimodal imaging, which showed that this disease just is not a parafoveal disease, but it's truly a macular disease. And that's why the disease was renamed as MACTEL, that is macular telangiectasia. Outer and inner retinal cavitation, ellipsoid loss, and slow macular atrophy over a period of many years is the natural cause of this disease. Using multimodal imaging, by which we mean color photography, short wavelength autofluorescence, blue reflectance imaging, and SD-OCT with OCTA, we now do know that this disease occupies a larger area of the macula. You can see the increased autofluorescence in a circular fashion, and this area has been described as what we call as a MACTEL area today. If you see the fundus fluorescein angiography, it shows a very small area. But then if you see the autofluorescence, you can see it involves a much larger area, and that is what is described as a MACTEL area. Therefore, from being a vascular disease way back in 1980s, today we know it's a neurogliovascular degenerative disease. And postmortem examination of one patient with established macular telangiectasia showed us there is loss of Muller cells and subsequently photoreceptor loss. Confocal blue reflectance or blue reflectance imaging, probably the earliest sign in clinical examination or investigation, even before OCT shows us any evidence of the disease. This is because the macular pigment is reduced, and blue reflectance imaging at 488 nanometer is reflected more, and that's why you see a mild hypoautofluorescence in the region of the fovea, where usually we get a hypoautofluorescence. The earliest changes in OCT, which we documented, is foveal flattening and parafoveal thinning. You can see the temporal parafoveal area is thinner than the nasal parafoveal area, and we see these hyperreflective dots, especially in the outer plexiform layer. We really do not know what's the exact reason for that. Subsequently, outer retinal changes start. I have shown you, we are now working on long-term follow-up of some of these patients, and we have two sets of patients here, the one on the top and the one on the bottom. The top from A to D is one set of patients over a period of 5 years follow-up, where initially the OCT was normal, and subsequently you can see a foveal ellipsoid loss. This is a different phenotype where the disease progresses very slow. Compared to that, to the lower set of patients, OCTs, where you can see the parafoveal cavitation progressing to ellipsoid loss, and finally progressing within a period of 4 to 5 years with significant ellipsoid loss, you can see here. So there are two different phenotypes of this disease, and we have also described this particular finding very recently, where we showed this foveal type of involvement in macular telangiectasia, which can be confused with many other diseases like ocular macular dystrophy. Therefore, over the last 10 years, there has been a concerted attempt of devising a new classification system for macular telangiectasia, and the MACTEL group recently came out with a robust classification, which I feel can be implemented in clinical practice. It's very easy to apply, and it is related to visual acuity loss. So that's very, very important. Therefore, you can see here from grade 0 to grade 6, there is a natural progression of the disease, and with each stage, there is a decrease in visual acuity. Ellipsoid loss and outer retinal hyperreflectivity are the two important biomarkers to tell us the natural progression of the disease and what affects the visual acuity. Therefore, we recently validated this data in a large cohort of patients in a multicentric study, and you can see that from grade 0 to grade 6, the visual acuity slowly decreases, and patients with grade 6 have far less vision, and these are the patients who have advanced disease. So this is a beautiful photograph to show you the various stages. So this is the grade 1, where you have the parafoveal ellipsoid loss, and then we have the foveal involvement, and then we have the parafoveal pigmentation, and subsequently the outer retinal reflectivity, and subsequently the pigmentation that progresses towards the fovea, resulting in macular atrophy, and lastly the subretinal neovascularization. Therefore, this is a very robust classification. And if you see some of these patients in a long-term follow-up, this is one of our patients with a long follow-up, and you can see every year the OCT shows slow increase in the ellipsoid loss. And subsequently, you can see what we call as the outer retinal hyperreflectivity, which has nothing but hyperreflective areas on the surface of the retinal pigment epithelium. And this is a very important finding, because outer retinal reflectivity is associated with outer retinal neovascularization. So recently, therefore, ellipsoid loss is one of the most important biomarkers, and it indicates photoreceptor loss. And therefore, recently, the phase 3 results of a randomized trial using cell-based ciliary neurotrophic factor therapy for macular telangiectasia was published, which showed us that ellipsoid loss definitely is reduced, because neurotrophic factors are basically result in animal studies in eye with outer retinal degeneration. There is a decrease in photoreceptor loss, and this was clinically applied by placing genetically modified retinal pigment epithelium in the pars plana, which is slowly released over a period of 14.5 years. Though the phase 3 results were recently published, and it was one of the probably a 2-year follow-up. We need a longer follow-up because this is a slow progressive disease, but nonetheless, probably this is the first indication of some treatment to control this particular disease. Therefore, the NT501 is a novel cell-based therapy where the ciliary neurotrophic factor is slowly released, and this probably is a landmark as far as the treatment of macular telangiectasia is concerned. Coming back to the disease, I would like to differentiate between outer retinal hyperreflectivity and subretinal neovascularization. It's very, very important, because outer retinal reflectivity is associated with a neovascular network. This neovascular network is not an active neovascular network. It is basically arising from the deep capsular plexus, and therefore, when you do manual segmentation, you can understand this, and this should not be confused with exudative macular neovascularization. This is the eye with the exudative macular neovascularization, where you can see there is definite shrem or outers or a mound-like hyperreflectivity on the surface of the retinal pigment epithelium. And if you do the octa, you can see this dense network, which is an indication of a subretinal neovascularization, which requires intravitreal anti-VEGF therapy. Therefore, I have just tried to elucidate some of the important features of a disease which is less spoken about. Macular telangiectasia is basically not that uncommon, and careful examination and multimodal imaging can identify some of these patients and prevent you from making a misdiagnosis of mimickers. I would like to thank my team, our fellows and people in the retina department who have contributed a lot over the last 10 years in the SMACTIL project. And this is Dr. Kiran Chandran, who is one of our medical retina consultants who has been working on this disease, and also Professor Shobha Shivprasad for motivating us to generally move ahead with this project because of our large data. And finally, I would like to conclude by paying my homage to my mentor, Padma Bhushan Dr. S.S. Badrinath. My professional journey has come a full circle from being a fellow, one of his earliest fellows, more than 4 decades ago, along with the likes of Lingam and Cyrus. Today I'm here sharing the dais, delivering a lecture in his name. It speaks volumes and the impact that a gentleman can make in a professional career, not just mine, many more like mine, and who have been nurtured over the years to perform better and better. Thank you all for your kind attention, and thank you, the Society, for honoring me.
Thank you, sir. Thank you, sir. So now we move to the next set of awards, which are the general awards from the AIOS Scientific Committee. And one of the most prestigious awards in this arena is Dr. P. Sivareddy International Award. This award is instituted in memory of Dr. P. Sivareddy, which recognizes the contribution of the international stature in ophthalmology. The award is presented for any global leader whose work is significantly advanced eye care, research, and surgical innovation. And this year, the AIOS Scientific Committee and AIOS headquarters is extremely honored to bestow this award on none other than Dr. Harminder Dua sir. Dr. Harminder Dua sir requires no introduction. Please give him a big round of applause. Dr. Harminder Dua sir requires no introduction, not only in India, but all around the world. He is the chair and the professor of ophthalmology in the University of Nottingham. And most importantly, he has been credited with the discovery of the 6th layer, which is known as now the Dua's layer, which is the Brie-Desmet's layer, and its impact on the corneal surgery. And Dr. Dua is going to deliver his lecture in the same regard. Thank you so much. Thank you.
Thank you very much. I could start by giving my heartfelt thanks to AIOS for this high honor. P. Sivareddy was one of the giants of Indian ophthalmology, on whose shoulders many subsequent generations have stood tall. Amongst his many accolades and achievements, he is credited with the largest number of cataracts performed by a single individual, over 250,000. For his services, he was awarded the Padma Shri and Padma Bhushan, deservedly so. It's an honor to give this talk in his name, and I've had personal interaction with him in Nagpur when he came as an external examiner, as a good friend of Professor Ishwar Chandra, who was my mentor and teacher. When I gave this topic, I was not aware that I had only 8 minutes to cover it in, so I'm going to rush through some of the slides, but hopefully focus on the last 4, where I will tell you something new. The DALC operation, the video you can see, as we've seen also very elegantly performed by Sujata Mohan in her talk, was believed to be a Desmet's bearing operation. Everybody said you're bearing the Desmet's membrane, but there were certain clues that suggested to me that that's not the case, that there's another layer. And looking back in the literature, just as we had predicted, below the last row of keratocytes is that zone. You can see over years it actually thickens, and that is the layer we were talking about. So based on these clues, we hypothesized that there is this layer and set to prove it by simulating the operation in eye bank eyes. We were able to show different kinds of bubbles. The main were the 2, type 1, where the bubble is central, as made of a thicker wall than the type 2 bubble. So that's the type 1. The type 2, where the bubble starts at the periphery, is a much thinner wall and extends across the entire posterior surface compared to this one which is in the center. And occasionally the two occurred together, where you had the type 1 in the center and a partial type 2 or a complete type 2. We called it the mixed bubble. So what was happening in the patient's eye was actually this, and not what we thought it to be. This double bubble, where the mixed was occurring in the eyes, was attributed to a split in the Descemet's membrane. And that actually was not the case, as we showed over here. And this was really the first slide where, the first video where we proved that there's this layer. So you can create a type 1 bubble, you can peel off the entire Descemet's membrane, and the bubble is still there. If you get the type 2 bubble and you do that, the bubble collapses. So this layer that we see was the layer we are talking about. And no matter where you peel the Descemet's from, a type 1, type 2, or a mix, there was never a split between the banded and non-banded zones. So that concept that the mixed bubble is a split was also wrong. The impact on surgery is we could now tell the two types. The type 1 has a very roughish appearance, the type 2 has a very smooth appearance. You can get a very good, complete DALC operation with either type, but type 2 is very vulnerable, and we now know that we have to take certain precautions. We knew that this layer provides a cleavage plane, so even if you get a very small bubble, you can exploit it to extend that bubble manually, extend the cleavage plane to its limit and complete the operation. Or, as you see in the video on your right, you can peel off the entire anterior stroma from the pre-Descemet's layer, and you can create a nice operation if you don't get the bubble. The type 2, like I said, is very vulnerable. You can see a little nick over there and the bubble bursts, or even when you put some extra pressure on the eye and you move the eye with a type 2 bubble, it can burst. Now, these are disastrous situations which we can completely avoid by knowing which type of bubble we've got, which we now know because of this discovery, and we can understand that, and we can complete the operation successfully by taking certain steps and avoiding certain harsh maneuvers. Knowing the strength of the layer, we could now perform the complete cataract operation. So this discovery has led to the innovation of 3 new operations, and one of them is the DALC triple. The entire cataract procedure with implant can be done under the pre-Descemet's layer. If you're doing a DALC and you find there's a cataract underneath, you can do that, and that's now called the DALC triple operation, which was first done by Zaki. Others have done it before this, but they thought they were doing the operation under a Descemet's membrane. If you get a type 2 bubble, don't even try it because it will burst very quickly. Descemet's bursts at 60 millimeters of mercury pressure. This layer bursts at 700 millimeters of mercury pressure. We can also do endothelial keratoplasty, very important for young donors. You cannot peel the Descemet's membrane in young donors because it tears, and even if you get it, it's so thin it's difficult to unfold in the eye. But with this operation, by creating a type 1 bubble and by excising it, you can use it for the operation which is now known as the pre-Descemet's endothelial keratoplasty, or PDEC. We first postulated and presented this idea, which was subsequently popularized across the world by Amar Agarwal. And these are some outcomes of that. And also, Professor Murain from France have showed that the third innovation surgically is that if you approximate the torn edges of this layer, you can successfully treat acute hydrops in keratoconus. But more importantly, or equally importantly, is its role in corneal pathology. We know now that acute hydrops is not due to tear in the Descemet's membrane in keratoconus, but to a tear in the Descemet's membrane and the pre-Descemet's layer. We know now that Descemet's membrane detachment follows exactly the 3 types of bubbles. The type 1, where there's the pre-Descemet's layer, Descemet's membrane, and endothelium. The type 2 is the true Descemet's membrane detachment, and the mixed type, where both are detached and also separated from each other, and it can be torn to cause a rhegmatogenous detachment. This has implications for treatment of the pre-Descemet's detachment. The pre-Descemet's layer, when it's detached with the Descemet's, is much more difficult to put back compared to Descemet's membrane detachment alone. We know descemetocele can also be of different types, and that in deep infections, particularly fungal infections, you get a type 1 detachment with inflammatory debris accumulation, and intracorneal hypopions are also due to the separation of that layer, as you can see, the predesmate detachment with the fluid level. But just want to finish off drawing your attention to this. Hopefully, I'll maybe take 30 seconds extra. We had shown that the predesmate layer continues as the trabecular meshwork. The trabecular meshwork is not an isolated triangular structure. It is part of the back of the cornea. On scanning EM, you can see if you take the descemet off, this is the predesmate layer continuing as the beams of the trabecular meshwork. So how is this important? We created this artificial anterior chamber perfusion model of the eye, and you can see the mount over there, the fluid perfusing into the anterior chamber, and you can normalize it, standardize it, optimize it. You get a steady aqueous outflow. Now, we know that in DALC operations, the incidence of glaucoma is much less than in PK. In penetrating keratoplasty, it's attributed to the tight sutures, but DALC needs equal number of sutures. Why should the glaucoma be less? We postulate that if you cut the predesmate layer as you do in penetrating keratoplasty, you alter the biomechanics. Biomechanics alter the expression of proteins leading to glaucoma. So we took the eye bank eye, we made a 180-degree cut just in the predesmate layer, mounted it back on the chamber, and we were able to show that the aqueous outflow considerably reduces if you have made that cut, and does not if you don't. And you can see over here, not only does it reduce the aqueous outflow, but profibrotic proteins are increased in expression on immunohistology in the area where you have cut compared to the uncut area and in controls. And in the effluent, the fluid that comes out, if you measure MMP9 and MMP2, it is more when you make the cut compared to where you haven't made the cut. And even myocilin, which is one of the genetic disorders in chronic open-angle glaucoma, is expressed in more in the effluent on day 9 when you have made the cut in the predesmate layer compared to where you have not. So the implications of this layer in glaucoma are just beginning to come through, and we think that this will be very important going forward when more research is done in this area. So just to summarize, the profibrotic expression after you make the cut can be responsible for glaucoma. So in summary, the discovery of the layer has improved our understanding of endothelial keratoplasty and anterior lamellar keratoplasty procedures. It has helped in innovating new procedures and techniques and maneuvers to avoid challenges of these procedures. It has shed light on corneal pathology, changed our age-old, some concepts more than 100 years old, of acute hydrops and descemet membrane detachment. We know now they are not what we thought them to be, and it is likely to play a role in corneal biomechanics, particularly posterior biomechanics and in IOP maintenance. Thank you. These are the references.
Thank you, sir. So the next award is shall be given to a member who has made a composite contribution, both qualitative and quantitative, in the posterior segment of the eye. And this AIOS Shroff Award is awarded to Dr. Lalit Verma, sir. He is the Director of Internal Service at Center for Sight for work done in posterior segment in India. Over to you, sir.
Good morning, respected dignitaries, members of the Scientific Committee, Professor Radhika Tandon, the Chief RP Center, dear colleagues and friends. As I stand today, I'm actually deeply honored and humbled to receive this prestigious C.N. Shroff Award. Thanks to the Scientific Committee led by Professor Namrata Sharma and all the members, as well as the AIOS office bearers, for bestowing this award on me. See, to be associated with the legacy of Dr. C.N. Shroff, whose vision and pioneering work helped shape modern ophthalmology in India, is truly a privilege. This recognition is not merely a personal milestone. It reflects the collective support of all my mentors, in particular Professor H.K. Tiwari, the colleagues, Dr. Dinesh Talwar, and the entire retina team at RPC, the students who play a pivotal role in motivating you day in and day out, and the institutions which have shaped my professional journey. See, these are the few pictures which I could gather of Dr. C.N. Shroff. A lot of people may not be aware that C.N. Shroff, he set up his practice in Mumbai on his return from London, and he was the elected secretary of AIOS and also served as president in 1951. You see, my association with retina began during my years at RP Center in 1985 at AIMS, when I had the privilege of learning, teaching, and building clinical as well as research programs in VR diseases. And over the years, our collective work has focused on advancing the management of various retinal disorders, in particular central serous retinopathy, then various aspects of VR surgery. We started with 20 gauge at that time, then laser treatments of diabetic retinopathy, and evolving therapies of ARMD as well as other sight-seeing complications. A particular area of my work has been addressing preventable causes of blindness, including diabetic retinopathy, infectious complications such as endophthalmitis. And I had the opportunity to work extensively on endophthalmitis, having led as a principal investigator in 11 theses at RP Center. And endophthalmitis is a devastating yet potentially preventable complication of intraocular surgery. So one of the areas which we explored deeply was the role of silicone oil tamponade following vitrectomy in cases of very severe endophthalmitis, where we thought it can help stabilize the intraocular environment and support better anatomical and visual outcomes in selected patients. You see, we all understand that antibiotics, thanks to the work done by Dr. Ghulam Peyman in 70s, are the mainstay, but vitrectomy is required in a lot of these unfortunate eyes. So every eye may not respond to a combination of vancomycin or vancomycin. There are severe patients of severe endophthalmitis who are non-responsive, or patients who have end-off on day 1 or 2, that means very virulent organisms, and patients who present early after surgery with overwhelming inflammation, bleb-related endophthalmitis, and PL plus minus kind of vision, and where on ultrasound exudates extended up to the retinal surface. Or in a lot of these patients are post-traumatic polymicrobial endophthalmitis, fungal etiology which is suspected or diagnosed, then chronic endophthalmitis, and a lot of other things also, and associated RD also. So here vitrectomy, what was initially taught to us, core vitrectomy, I personally believe in today's era has no role. Therefore I crossed it here. It is the radical vitrectomy which we do. You see, I remember still one patient which Dr. Dinesh Talwar was doing at that time, and we were hoping that a break may happen. Because if break happens, that you necessarily put the oil. We had put the oil, but this eye did phenomenally well. We tackled the break, but infection also ultimately went away. So radical vitrectomy is the call of the day. It is necessitated in all patients who have very severe endophthalmitis, where the ultrasound shows exudates right up to the retinal surface, and vision sometimes is reduced to PLPR only. So, but before we undergo radical vitrectomy or take these patients up, it is very pertinent to clear the anterior chamber, because if you do not clear the anterior chamber, you may do a messy job in the vitreous cavity. Because vitreous surgery is all about seeing. If you see well, you can do well. So first step is always to use this wonderful instrument, AC maintainer sometimes, and then make a stab incision and take care of this fibrinous membrane or exudative membrane over the surface of IOL, iris, tease it away with the help of this 26 gauge needle. And after this has been done, then you go inside and do a radical vitrectomy. In some situations like these where it's very difficult to go inside the anterior chamber, what we described long time back was that you go from the pars plana. You, after putting a 6mm cannula, straight entry, because a lot of these patients have thick choroids and you have to use 6mm cannula. So instead of going from the anterior chamber with no space and the limbus is ectatic, so we go from the pars plana. From the pars plana we make a hole in the iris,
And through that hole, all the instruments are then introduced to clear up this mucky exudates which are stuck. Because if you don't remove this, this was actually a one-eyed patient, a mercy kind of surgery was done. Remove all these exudates. There may be some ooze, but we still, keep persisting like this. Very, very old video actually, and this was the IUL which patient had, and since limbus was not very good, so after having teased away all these exudates from the surface of iris, we explanted this IUL also from the pars plana itself. Enlarged this incision and took out the IUL, and then sutured the thing, and then after that paid attention to the vitrectomy. This was enlargement of the incision. This IUL comes out, suture, reduce the size of incision then, and do a depression. This took more than 2.5 hours of painful surgery, endozyrotomy, and finally filling up with silicone oil. This was, you see, the another patient actually, where patient had similar kind of very severe infection, had received antibiotics also, grew klebsiella in the culture, and these are silicone oil reflexes post-operatively. Patient regained finger counting vision only. This was a lady who had undergone multiple vitrectomies before she came with a corneal abscess to us, and this was the picture at presentation with no glow and PL kind of vision. And this is the surgery we did similar what I showed before, that go straight inside, first tackle the anterior chamber and remove all this exudate after putting a stab incision, protecting the endothelium with visco. Try to tease away this exudative membrane, thick exudative membrane was there. Remove it with the help of this bent needle, 26 gauge. Also remember to sever all these connections between the corneal abscess and the intraocular cavity. And IUL explantation also was necessitated because we were not able to make any headway in the surgery. IUL was, one haptic was missing. Then this became aphakic area, and this all the exudates sutured the wound, did a depression vitrectomy, and ultimately this patient had good vision of 624 with silicone still inside. So fungal endophthalmitis again is a challenge. Repeated vitrectomies, repeated intraocular injections are required. But this patient who came with multiple surgeries, the only thing we did here was to tease away the hyaloid face, because a lot of these colonies were under the hyaloid. So only surgery we did here was to remove this hyaloid with the help of this black flesh needle. This is post-op result of one of the patient who had post-traumatic fungal endophthalmitis with silicone oil, and this photograph lower below shows after silicone oil removal. So this was another patient who had P. acne kind of endophthalmitis from Uttar Pradesh. I remember this lady had multiple surgeries done, and this patient had suspected P. acne infection, and we had to remove the IUL in this patient also after mobilizing this IUL. And after this IUL was out, tease away all this whitish looking retroiridial capsular bag, because the bug is in this bag, and then fill up with silicone oil. So thus to conclude, in all these patients who have very severe endophthalmitis, this combination of radical vitrectomy plus silicone oil improves not only the anatomical but sometimes visual outcome also, because we believe that silicone oil compartmentalizes the eye into anterior and posterior segments. Anterior segment is can be managed by topical therapy, and the vitreous cavity, which is now very trimmed, filled with silicone oil, is impermeable. Filled with silicone oil is impermeable to any organism, and rest of the space can be tackled by systemic drugs. So early vitrectomy and radical vitrectomy with silicone oil brings smile back on the patient's face. So I'd just like to thank once again the entire team of AIOS for considering me worthy for this award, and thank you very much for your invitation.
Thank you, sir. So the next award is the joint award, Dr. K.R. Datta Award, for a particular work done, a significant work done in India. This goes to Dr. Rangaraj Venkatesh, Chief Medical Officer, Chief of Glaucoma Services at Aravinda Hospital, Pondicherry. The topic is strengthening opportunistic screening and management of glaucoma through innovative approaches.
Thank you. I take this opportunity to thank AIOS Scientific Committee who are seated here and my friends, my colleagues, and also would like to dedicate this to Dr. K.R. Datta, who has been a pioneer in community ophthalmology. So we all know the problem of glaucoma is increasing day by day, and we know the burden is going to be somewhere in 2040, 112 million, and second leading cause of blindness. But most of the time, what we say is we diagnose glaucoma late, so unfortunately we can't do much. But early detection is the key, and we need to take a lot of efforts so that we can detect early, preserve their quality of life, and also create awareness and adherence to medication wherever possible, not least in the mild and moderate stages, so that you can reduce the need for surgical intervention. Otherwise, most of the time it is advanced glaucoma and the treatment is more surgery. So I would focus on few experiments which we have done in the last 2 decades. One is really on the high-risk screening. I just want to introduce this eye-opener family. Many of you will have a lot of experience in glaucoma, but this was an eye-opener for me. My colleague is examining here, but this was one of the mother of our insurance staff, Devi. And then it was Devi's housewarming ceremony. And I said, who has come for the housewarming? Saying, Amma, my mother's all 3 sisters. Can you get everybody in the afternoon for examination? And they all come, and you see them sitting there. This happened 20 years back when they had black hairs and when I had black hair. But over the last 20 years, I've been closely following this family. All 4 had glaucoma. This made us really work on angle closure, and this is what we found. We found that 1 in 3 had a risk of developing angle closure. If you're a proband, it is worth examining all your siblings or children, or even if your parents are alive. And we went on to do this study, and we had 13 publications starting from this family and doing an Indian family angle closure study. And I don't want to really get into the study, but what we at least understood was just by telling to screen is not enough. We have to go beyond that. We have to really get the family. And that's where we started something called the F-Page project, or the Family Primary Glaucoma Evaluation Project, which happened in the last 3 years. It started just after COVID. From Pondi, we took the project across 5 tertiary care centers. And what we did was basically, we were giving some sibling screening cards. We were kind of telling the probands to bring their siblings, but it didn't work. So we had to go one stage beyond. And now through the electronic medical record, what you see is an old record which is being filled up. But now with the EMR, and we have something called the family software program, which is integrated to the EMR. These are the old cards which we used to give, and the feedback was less than 8%, or the response rate was less than 8%. But once we could integrate with the EMR and send an automated SMS or a WhatsApp message to the sibling and offer them a free screening in the base hospital, we were able to screen a significant number of people. In the 3 year of project, we were able to see close to, we sent 85,000 WhatsApp SMSs, and we got 31,000 relatives back into the system, which was the response rate of almost 36%, which we never had in any intervention before. And the total glaucoma patients with the suspects were close to 22%, and if you take glaucoma alone, it was close to 5%. That's the kind of yield which you will have if you really strengthen the family screening. And many of these are early glaucomas, and you pick up these glaucomas very early. I'm sure you recognize that person. It's Soumya Swaminathan, who came during COVID time because her father was closely working with Dr. V. She wanted to see one of the Aravind, and I was fortunate to meet her. And she introduced to me something called the shared medical appointments. She said, I heard there is one crazy person here, and that's you. You're the only one who can do this project. And normally a traditional appointment is one-on-one, where you sit with one patient and you examine them, and all your other patients are either in your hall or on the corridor. So what she told me was, if you have 5-8 patients, they do this in Cleveland Clinic, you try this. It works in obesity, it works in COPD, it works in diabetes. I'm sure it will work in glaucoma. So the group of 5 with primary glaucoma share an appointment. You do all investigation, and as you see in the video, they sit with you in your room, and the other 4 are also primary glaucomas. When you are examining and talking, they are all listening to you. No, the experience is being shared. The treatment is being shared with the consent of all these patients. We did a big trial, and this was published in the last couple of years, and this was one of the biggest randomized trials on shared medical appointment and in glaucoma as well. And what we saw was, interestingly, the knowledge was better. These were all done by very meticulous survey and things like that. There was higher satisfaction among these patients, and also medication rates were much, much better, the compliance to medications. We followed these shared appointments for the next 2 years of 500 one-on-one and 500 on the other side who shared their appointments. And what is the other interesting thing, again, you can see my colleague there who is discussing with the same group of shared medical appointments. So we were the 2 people who did this randomized trial, and there was a great engagement of the patients. No, they were asking more questions, they were nodding their head. So we had 30,000 minutes of recording, and the medical transcription was done to find that there are 33.3% more questions, 8.6% non-question comments like gesture and all that. So these were some of the interesting things we saw in this particular project. And this is one simple project which we did from 18 to 40 years, and we found that 1 in 535 will have glaucoma. So even if you have a younger clinic, less than 40, make sure you check their intraocular pressure. I'll just go to quickly the opportunistic screening, especially our vision centers, where we do a lot of work through our 119 centers. But what we have seen is, just by imaging the fundus, you can detect a lot of posterior segment disease. So this is again a study which we did pre-COVID. We did a kind of a cluster randomization in 4 of our centers. And what we found was, when you take a fundus image, there is a significant increase in the posterior segment diagnosis, especially glaucoma, diabetic retinopathy, and other conditions. And let's say if you have an AI in your camera and it can do an artificial intelligence. Again, we did a work a couple of years back with the Remedio team and found that the sensitivity and specificity of AI when compared to a telemedicine doctor was good. The false positives were significantly less when compared to my resident doing teleconsultation. So AI did a definitely better job, and we can prove. These are all pragmatic studies which we did. And finally, I'll just finish with outreach work, because we all know outreach is cataract centric. No, we did these eye camps for many years, but now we tried a novel way of outreach by doing eye care, by doing a fundus imaging, and now with the new AI, now we have taken the project to another level, but this was before the AI period. Again, a significant increase in the posterior segment diagnosis. No, there is no doubt that if you can image, because the community setting is not that easy for a lot of things. If you can image and have that on the EMR in front of the doctor, as you see in the video there, now we had to take EMRs, we had to, computers and tablets and things like that. It takes 1 hour more than a normal camp, but it is worth doing for the kind of PSD it can diagnose at a much, much early stage. And this is what now we have kind of proven, and now Orbis has kind of collaborated to take this to the next level. So finally, I'll just touch on something which we really developed in our institute is the IVA. And now you have IVA, you can go to the trade and check how it really works. Now we have very good validation on neuro-ophthalmology and in glaucoma, and we found that it's really good for screening your glaucomas, especially if they have mild to moderate glaucoma. The AUC is almost 0.86. So by doing all this, in the last 2 decades, we have played a significant, but my point will be again to strengthen your family screening and also opportunistic screening wherever possible, so we can pick up glaucoma at a much early stage. Thank you.
Thank you, sir. The same AIOS KR Datta Award is jointly awarded to Dr. Praveen Vashishta also. He is the officer in charge, Community Ophthalmology, Dr. RP Center for Ophthalmic Sciences, New Delhi. And he would be talking to us about work on epidemiological research, surveys, and strengthening public health in eye care India. Dr. Praveen Vashishta. Okay, we'll go to the next one. Okay. He's not there, maybe he'll be a bit late. Next is AIOS SC Dutt Award, Dr. Manpreet Kaur. She is an assistant professor, cornea, cataract and refractive surgery services, RP Center for Ophthalmic Sciences, AIMS, New Delhi. She'll be talking to us about intraoperative OCT in anterior segment surgeries.
A very good afternoon to all of you. I'll be presenting our work on intraoperative optical coherence tomography in anterior segment surgeries. So if you look at the journey, it actually began, so this survey article is a compilation of all our work on various innovations in anterior segment surgery and has enhanced our understanding of the surgical dynamics. And if you look at the beginning, the retina people were the one who first started using IOCT for ILM peeling, etc. And from there on, we got the idea that how can we incorporate into anterior segment surgeries. So one of our first publications, we said that let's try measuring the vault of phakic intraocular lenses on table, because whenever something new comes, to integrate into what is actually already known is a bit difficult. So this was one area where we thought maybe it has some potential beyond the usual and will help facilitate our surgical decision making. So the original IOCT did not have a on-table inbuilt scale. We used a ruler on the screen to measure the height of the screen, and the depth of the acquisition was 2000 microns, and with a unitary method of conversion, we came out with a factor of 7.5 after back and forth with the Zeiss engineers, and this led to our first publication in which the intraoperative vaulting was said to correlate with the postoperative vaulting. Now the newer versions have an inbuilt scale, which the genesis was this back and forth with the engineers that we had on the need for a on-table measurement device. From then on, our innovations and contributions spanned phacoemulsification, refractive surgery, and keratoplasty. In phacoemulsification, one of the dreaded complications in white cataract is the Argentinian flag sign, even in the best of hands, when the capsule just extends irrespective of what you do and however small the initial nick is. What IOCT helped us understand is what happens in real time, so we classified the cataract into different subtypes, and in this subtype, the one which is prone to the Argentinian flag sign, there is no release of fluid, the cortex is in toto and just bulges with a positive intralenticular pressure, and this is going to lead to a capsular extension, and a bimanual IA is the only way to relieve the tension by breaking the continuous cortical cords. So this was one of our innovations which led to our publication on a novel classification system using intraoperative optical coherence tomography, which also includes management strategy based on which type of white cataract it is, based on the intraoperative OCT features, and also gives the management for each kind. Like in type 1, you can go ahead with a normal rhexis. Type 2 is the one which is prone to Argentinian flag sign and requires IA. Then posterior polar cataract with pre-existing PC defect, of course, can be picked up either preoperatively or intraoperatively with OCT. What about the ones that do not have a pre-existing defect? So we again classified them into 3 different types, and the classical teaching said that don't do a hydrodissection. We challenged it because in one subtype in which you can see the posterior capsule in its entirety, you can do a hydrodissection, and the whole posterior polar complex delineates from the posterior capsule, as you can see very neatly on the intraop OCT, and the further cortical cleanup is much easier. So you can actually see the hydrodissection delineation waves and the posterior polar complex separate from the PC and an intact posterior capsule. So this again led to our classification system in which the incidence of posterior capsular rupture in the type 1, in which we did do a hydrodissection, was 0%. Then we observed the incision morphology and incision site descendant membrane detachment, and observed that a ragged morphology was more prone to have a incision site DMD, and this ragged morphology was more with keratomes, blunt keratomes, and femto laser assisted incisions actually had a more smooth morphology and lesser incidence of DMD. Coming to corneal surgeries, the main application is in lamellar corneal surgeries rather than full thickness, and in endothelial keratoplasty, right from graft donor preparation to intraop lenticule adhesion, in all steps IOCT has proved to be invaluable. In donor preparation, actually ultrasound, once you have cut, you cannot accurately assess the residual donor lenticule thickness even with the ultrasound because it starts giving error. IOCT comes to the rescue here, and even in selection of the appropriate microkeratome head. Now one thing that we challenged was the time required for complete donor apposition. What traditional teaching said at that time was wait at least 8 to 10 times more in cases of complications. But as Ramanjit ma'am is sitting here, if you have a glaucoma case, 10 minutes of continuous positive pressure is going to snuff out in advanced cases. Here, after intracameral air, this is when we start the maneuvers, and you can see in real time apposition happening and the interface fluid decreasing. And this changed the concept of waiting for 10 minutes in every case. In fact, in most of cases, the apposition happens in 1 minute and you don't require a continuous positive pressure. Acute angle bevel sign was another innovation by us, in which you can see in ultra thin grafts in which the double ring sign does not works as well, you can see this acute angle at the graft edge, and this tells you that the lenticule is in the correct orientation with stroma up and endothelial cell down. In DMEC, of course, graft unfolding has been described by various authors, and even if it clinically looks okay, you can see here that it is inverse on the intraop OCT, and you cannot really unfold and check for the S mark because by then you have already manipulated 2 times. So this you can just flip with gentle fluidics and then see the complete attachment on intraop OCT. In anterior lamellar keratoplasty, it can help in identification of subclinical big bubbles. In this, we were not very sure if the big bubble has formed or not, and we are going layer by layer, but IOCT is telling us that there is an intact decimates, and in Dua's layer or the double pre-decimatic layer can be clearly seen, and IOCT is here helping us identify a type 3 or a mixed bubble in which the pre-decimatic and the decimatic layer have split, which may be difficult to appreciate clinically. And manual by manual layer by layer LK is where IOCT really shines, because it helps you go as thin as a near decimatic DALC manually, because you know that there is a safety margin and you can visualize it. So if you can see here, we have, if you see a big bubble DALC and a manual layer by layer, you can actually go as thin with the help of an intraop OCT. And in corneal hydrops, we can see the suturing, the apposition of pre-decimatic layer, as Dr. Dua was also saying, and you can see that partial thickness sutures are as efficacious as full thickness sutures. You don't really need to put full thickness, and suture tension and placement are what matter more than the depth of placement. In refractive surgery, I already told you about our innovation in phakic intraocular lenses. Then of course, if you inject the lens inverse, you can see it on IOCT, and this is an indication to explant and correct. It has been a rescue tool during lenticle extraction procedure in which you have a cap lenticular adhesion. Of course, the caveat here is that it is not integrated in the microscope, surgical microscope, so that is where we can further work. In cases of complications post-LASIK epithelial ingrowth, you can lift a localized area rather than relifting the entire flap and then peel off the ingrowth. What the future holds is a seamless integration of intraop OCT in the surgical workflow. It's not just a gadget meant for institutions or those with extra financial capabilities. They do help in decision making, and what we need is instrument compatibility to avoid metallic shadowing, integration in the refractive suites, and improved XY tracking. So the eye sees what the mind knows, and IOCT, I think, helps the eye see better and also the mind to know the concepts better. It helps in elucidating the surgical dynamics. Thank you, and I would like to acknowledge my mentor, Professor Jeevan S. Tityal, whose vision it was in a majority of papers. Thank you so much.
Thank you, Dr. Manpreet. Next, we have AIOS B.K. Narayan Rao Award. Dr. Shushmita Kaushik, Professor Glaucoma Services, Advanced Eye Center, PG, Postgraduate Institute of Medical Education and Research, Chandigarh in India. She'll be talking to us about neonatal onset congenital ectropia nuvea, recognizing a distinct phenotype of childhood glaucoma and insights into underlying genetic variant.
Thank you. At the outset, thank you, AIOS Scientific Committee, for this honor, and I'd be happy to share some work in this area. So Dr. B.K. Narayana Rao, when I read him up, he has a small glaucoma connect. As we know, he was a founder member of the AIOS and actually presided over its 4th conference at Lahore in December 1936. So that's how old we are. He established the Mysore Medical College in 1925 and the Bangalore Medical College, of which he became the principal. He was senior surgeon of the Mysore state, which was the highest position of physicians at that time. And he was a palace physician in Mysore and also physician to the Nizam of Hyderabad. But after retirement, and this is where the Glaucoma Connect comes in, he set up the Prabha Eye Clinic, and Prabha Eye Clinic has Gauri in it. So Gauri actually messaged and said, you know what, this was Praveen's grandfather, so that's a bit of Glaucoma Connect that we have, that he is Gauri's grandfather-in-law. So coming on to the work, this is the paper that we published some time ago, a neonatal onset congenital ectropion UVA, which we thought is a distinct phenotype of newborn glaucoma. So congenital ectropion UVA is a rare abnormality. It is the presence of iris pigment epithelium on the anterior surface of the iris, and it's also been associated with systemic diseases like neurofibromatosis and Prader-Willi syndrome. But in our patients with neonatal onset glaucoma, we observed a phenotype of bilateral ectropion uvea and varying degrees of iris hypoplasia, and they appear to have a much poorer prognosis than neonatal onset PCG. So we set out to describe this, and we looked at our children, our babies who came with neonatal onset glaucoma, and to study its significance towards the severity and outcome. So we, of course, took informed consent and got the ethics clearance. So we looked at consecutive babies with neonatal glaucoma who presented to us before 4 weeks of age, and those with neonatal onset CEU, which is what we thought this was, and this is the ectropion UVA that we saw in these children, and we compared that with those without, which was only PCG and nothing else, and we looked at surgical outcomes at the end of a year. So we had 28 neonatal onset glaucomas, of which the CEU was in 12 and PCG was in 10. 19 patients with 1 year follow-up were analyzed. The outcomes were much worse in babies with neonatal onset CU compared to the non-CU babies, and this is the characteristic spindle-shaped corneal scar which remains. We were just discussing this with Dr. Murli, and we agreed that this is a kind of CYP1B1 cytopathy because of the distortion of the retinoic acid metabolism, which causes this to remain in the cornea. We saw varying grades of CU. It wasn't all the same, but all of them had this characteristic spindle-shaped corneal scar which remained despite having done a good surgery and the pressure being under control. So 17 eyes of the CU required a trab with trab, but sadly the 4 which underwent a goniotomy also required a trab with trab, so it didn't really work in them. And you can see that spindle-shaped opacity up there, even though we tried a goniotomy in some, but it didn't work. So what is novel about the phenotype? It's an independent adverse prognostic factor for newborn glaucoma. They have apparently worse disease than those without, and careful examination and follow-up was mandatory. So the next question was, is there any genetic variant which is different in this phenotype compared to the neonatal onset PCG? And when we looked at it, we actually found a specific genetic variant which resulted in the phenotype of neonatal onset CEU. So again, we went back. We went back to our babies who presented to us at less than 4 weeks of age. At that time, the NGS wasn't offering whole exome so readily, so we did a targeted, we curated a target of 21 genes which were most likely to cause developmental glaucoma. We used ACMG guidelines to determine pathogenicity, and their effects were also assessed by in silico prediction tools. And we included all babies who completed 1 year follow-up to see whether actually they were the bad prognostic ones. So out of the 13 patients with neonatal CU which underwent genetic analysis, 12 out of them, 92%, had all CYP1B1 variants. Now that was something, because CYP1B1 is traditionally been thought to be part of the PCG complex, and this wasn't PCG, this was CYP1B1, but interestingly, 9 of them, 83%, had the same variant, the arginine 390 histidine. And we look back at our children now, when we see them, all of them with this particular R390H present like this and have very, very poor outcomes. The compound heterozygous for CYP1B1, the arginine was substituted in all of them. Otherwise, the compound heterozygous CYP1B1 do well. But when one of them is an arginine which is substituted, they do really badly and they result in this. So there's something to do with the arginine metabolism of the CYP1B1 which makes them develop this severe phenotype and not merely PCG. Only one patient were heterozygous variants in 3 genes, which was not explained, but they came with the same phenotype of neonatal onset CU. Now, the closest description in literature to this phenotype was described by Professor Arif Khan, who also showed biallelic homozygous CYP1B1 variants. He called it partial aniridia because of the severe iris hypoplasia. And he was one of the happiest when our paper got out, because he said, at least somebody in the world is talking the same language that I am. So to summarize, neonatal onset CU appears to be a phenotypic marker for a specific CYP1B1 genotype. In our population, we observed it to be arginine 390H. The phenotype recognition is helpful to characterize the underlying genetic variants, and I acknowledge all my residents and the team for helping me work as much as I can. Thank you.
Next two speakers, I think, are on the way, Dr. Rajiv Raman and Dr. Sanjay Kumar Mishra. So I request Dr. J.K. Reddy, sir. AIOS Lalit Verma LV Pearl Award 2025, Dr. J.K. Reddy, Dr. Kasi Reddy Jagdish Kumar Reddy, Director Technical, Shankar Eye Hospitals, Coimbatore. He'll be talking to us about See Beyond the Eye, Learn, Earn and Enjoy.
No, thank you. There's too much about talking about the eye. I thought I was going to talk about beyond the eye. So these are only a few slides. There's nothing descriptive. So looking at the crowd, I can change my talk according to my convenience. So we are all doing good work and working for the good. That's the greatest advantage in the medical profession. You make the money and you make the people happy. That's not always possible with other professions. That way we are blessed by God that we make the people happy by making ourselves richer. That's very rare. So my talk is about learn, earn and enjoy your life. So when you come to the major economies in the world, we think that IT is good, automobile is good, then after our kids goes, no, I could have gone IT, I could have made money. But the major economy consistently for the past 150 years, no up and downs, is the health sector. So we are lucky to be in this economy. Remaining IT, automobiles, all, there are ups and downs. Even Ford bankrupt, GM bankrupt, Volkswagen bankrupt. Everybody is bankrupt except for few companies. In health sector, nobody is bankrupt. Everybody is growing only, they are expanding. So we are very, very lucky to be in this profession, that they have to make themselves believe that we are in a good place to work with. So what is the advantages? If you take globally, I traveled around the world except for few countries, South Africa, South America, maybe Greenland, something like that, Iceland, all other countries I traveled. A little bit Australia, I never been there, but Brazil, Mexico, somehow I missed it, Argentina. Remaining all countries travel, go around, see, not as a tourist, go around what is happening to the health. So, for example, for the health, preventive health care by any government is dismissal. Anywhere in the world, except in Singapore. Except in Singapore, remaining all countries, the health care, preventive health care by government, including the United Kingdom, is dismissal. So choice of health is left to the public, people. You do whatever you want, you live on yourself. So no systematic auditing and no resources allocation depending upon the auditing, and nil emphasis on preventive care. So there is no problem. You are going to have more patients, more diseases, and you will be more richer. You don't need to worry about that. That something is going to have, I am not going to have a patient, never going to work. You will have more patients. So there is a lot of things about the, I Google it or you read it, everywhere they say to live healthy. They give a lot of recommendations which are impossible to implement, or something sometimes. And you say healthy habits, they give a lot of things. In this thing, there is a saying in our philosophy, in this country's philosophy, whatever we think, we become. You keep on. It's only how sincere in your thought process. So you will become. You want to become PM, you can become. So how sincere in that? You want to become king, you can become. In the same way, there is in food habits also, they are given the sattvic, rajasic and the tamasic. So depending upon the food you take it, you will also change. Your character will change. So if you take on keeping the raw foods, they say like it's not our habit. This country's habit is not the raw food. It's a mix, cooked, fried, raw, all together. But some they say, you Google it, they say raw food is the best, the Mediterranean food is the best, you should not eat cooked or you may become like the raw animal which they use the raw food in one day. And I don't think nobody wants to go back and become like that which eats the raw food. In God we trust, everyone, most of us, maybe 1-2%, but all other people they got in trust. But for everything we need data. Data is the most important thing which runs the world. So here data comes the problem. In the data, you put a garbage in, garbage out. So that is a very important thing. I tell you a lot of examples like smallpox, polio, everything. Okay, we will go to the recent COVID as an example because everybody remembers this. Smallpox, they might have forgotten. A lot of people, they may not be knowing, some young kids about smallpox vaccine. So what COVID happened is, so all the deaths in the hospitals, they are written cardiopulmonary failure, septicemia, renal failure, respiratory failure, failure due to hypoxia and pneumonitis. Nowhere they are written cause of death as a COVID. So when the government in India calculated all the risk factors and data analysis and they want to go further, what is the preventive measures, what measures have helped it, all data became wrong. Only house deaths have written COVID, remaining all are written that. So in Tamil Nadu, 35 doctors on duty, 35 to 40 doctors on duty in government doctors, they died of COVID. So out of them, only 5 are written COVID, remaining 25 are written as cardiopulmonary nephrotic failure or something like septicemia, something like that. So the government has announced 10 lakhs ex gratia for people on duty who died due to COVID. These 25 fellows never got the money because the death certificate are not written COVID as that death. That's why once you put a garbage in, you get a garbage only out. So the data entry is very, very important. So added to that, we got a Google. Pichaya is from Tamil Nadu, our own area, from Madurai. He is creating more confusion for the patients and for us also. So when a patient comes us, he try to confuse with the Google knowledge. I tell them, please read for another one week and ask your wife also read, or husband read, father read, kids read, and come after 15 days. He will be totally confused and he will say, whatever you do it, I will do it. I will accept. So then future. They say everything was planned very nicely, they tell in the conferences, financial, everything beautiful. I used to attend, after some time I lost it because I tell you, they told me when I am doing my medicine, the future is refractive surgery. Then I learned refractive surgery, invested money, I lost all the money which I made for 10 years in refractive surgery. Then said multifocal is the future. The multifocal never crossed 4%, 5% of the market share. And now it is only 1%, and all companies have withdrawn the lens except in India and US, and they are going to withdraw all diffractive lenses. So, but anti-VGF, nobody told anything. That is the number one business in the ophthalmic industry now. Number two is the cataract. Nobody predicted, nobody expected. So don't never listen. If somebody says you think he's an idiot, you go out of it. So I tell you a few examples. This was published in 1989 in Illustrated Weekly. This guy, the producer, Ganga Jamuna Saraswati, he committed suicide. He jumped from 18th, 4th floor because he couldn't pay the money and he died. Then they published in 1899, the Amitabh Bachchan finished, he has to go home. One day everybody will finish. There is nothing to make fun out of it. Everybody hasn't. But after 35 years, he is in the top 5. Okay, what was finished, Illustrated Weekly of India. 1991, they closed it. After publishing 2 years, that article. They closed that magazine. So planning comes, education, finance, everything is there. But health is never budgeted. What we do is we make the money, we buy a car, anybody, me or yourself, anybody. Insurance policy. Health insurance policy is not health. Health insurance is a coffin after death. It's not a health. So there is no competition for you. It's just you versus you. Ego is the main enemy. Don't think ego is everybody will have ego. Ego is inherent character of human beings. Don't feel shame about it. By conscious effort, you can keep it under control. That's all you can do it. You cannot get rid of it. And it's only I versus me, and communication skills never stop learning, and money making is not a sin. So you remember, don't feel shame for anybody. Some people, they say, I am not a money minded. Who will work in India without paying money? I tell me, how many 0.1% will work if you don't pay money, ophthalmologist? I don't think more than 0.1% will work without paying money. So when you take 1 rupee, 100 rupee, what is the difference? Once you take a money, you take money. That's all. So so when it comes to the clinic, it's only lights, camera, and action. Don't give place for emotions and sentiments. There is no place for that in the clinic. It's only you pre-plan. It's like a movie. You have to act, you have to satisfy patient, you have to take your money. Both are happy. If you put your emotions and sentiments, both will be unhappy. Both you will not be happy, patient will not be happy. Attitude doesn't work. It's a permanent thing, is only the change. So never try to copy anybody. Be original for yourself. See, Kiki Mehta sir we are seeing from our undergraduation days. So I like many things from him. But I can never try to become another Kiki Mehta. It's impossible. I will become like another Joker. So I like some characters. I will try to incorporate in me, but I will try to make my own original. That's all. But he is there everywhere, sir, in the world. You cannot please everyone. So what happens in your institutions like that, where I am working, they say that one fellow writes saying that you may not be in the mood, you have some problem. They say this doctor today is not responding, that he will put a big mail in the Google form or something. Then the management will send in to make a big meeting, call everybody and say. So 10% of people will always complain. You do not worry. If you are 80%, 90% of the people happy, you can. If you are 100% happy, something wrong with you. It's not, you are abnormal. If you are 10%, 10% will be okay. You have to get rid of that. Anger has no place. So tips for management of anger. Now in the recent, anger also like ego is inherent, is built into you. It is the survival. Without anger, the whole society cannot survive. Humankind might have been extinct by this time. Because of anger, it is surviving. But with the present society, especially for doctors, there is no place for anger. Tips for managing anger, I don't know exactly. So God always gives a good chance, second chance. For example, I take only 1 minute extra. God always gives a good second chance. For me, as a childhood, my dream, I will tell example, is space travel. Get ejected into the space, no wife, no kids, no house, no car, no IT, no GST, nothing. Just travel forever till you disappear. I applied for medicine, I didn't get a seat. Like a stupid, I roam around and applied for second time, same marks, my marks. But other batch idiots, they didn't got less marks, so I got a medicine seat. So I did. I am standing in front of you. So what I could have done, God has given me a chance, not admitting it for 1 year. I could have pursued, joined in armed forces, taken a pilot job, and I could have tried to become and go to the space. Instead of that, I again roam around, eating coffee, tea, then again I apply. So we have to recognize the God. God always gives. When you want a chance, He will give, but you have to use it. If like me, you don't use it, I will be standing talking to you instead of somewhere in the space on the ground. Hard work, happy. I will stop with the last slide. There are many more. It will take 20 minutes talk, but I cannot. Hard work so working hard is not at all necessary. It's impossible. It's not necessary. It's only fancy word. If somebody says you worked hard, no. I enjoyed my work. I am working. Otherwise, I don't work it. If I don't like it, I don't work it. So some people will say that go and tell the children. It's very important for people who are 35 years, 40, who are going to have children. They keep on telling at the home. So I worked hard. I used to get up at 6:30 and go and attend my professor's surgery. Who asked you? That kid never asked you to go at 6:30, 5:30. So you only took a choice and went there. How can he is responsible for that?
Then one day evening they say, I don't have anything in my studying, no internet, no cell phone, and you are very lucky, you get all information. We used to go to library. If cell phone is not available when you are studying, how that kid is responsible for that? And sudden one fellow will say, no, I used to go in bus, city bus standing, and you are having, I'm giving a AC conditioned car and all, and you are not getting marks. And see, if your father cannot afford a car, how that fellow is responsible? His father can afford. So what happens with this nonsense talk at home is, the kind of subconscious hatred will come. It will come. Though you don't hate you, but the words hatred will come. You say drink coffee, he says I want tea. You say milk, he will say I want something else. You say whiskey, he will say I want wine. So this time, this subconsciously it comes up, and it disturbs entire your life. So don't do all those things. Change towards circumstances and enjoy your life. Thank you very much.
Thank you, sir. We have Dr. Sanjay Kumar Mishra now, Brigadier Dr. Sanjay Kumar Mishra, AIOS Preeti Natarajan Award. He is a professor and HOD of Army Hospital R&R, Delhi. Modernization of ophthalmology in Indian Armed Forces hospitals would be his topic.
Good afternoon, everyone. Thank you. I thank the organizing committee of AIOS for giving me this opportunity and honoring me, but it's an honor for my team. I dedicate this talk to my team, which I happen to be the leader of. Half of my team is here. So thank you so much. This is a journey which started almost 6 years back when I took over as the head of the Department of Army Hospital R&R. We were battling aging machines, lack of infrastructure. All those machines were, breaking down repeatedly. There was a big challenge to upgrade our hospitals, all hospitals, whether it was in Delhi or whether in periphery bordering the country in bordering Myanmar. My young specialists going there were frustrated because they were trained, they were going there, but they were not having any equipments. They were not having good microscope, no phaco machines. So they're feeling very frustrated going back as a fresh specialist and not having equipments. 3 years down the line, they would have finished. So it was a thing which was very painful for me to see. And so we started from scratch as a team. I built up a team and we worked very hard. Ma'am knows that how difficult it is to procure in a government setup. There are multiple machines, unlike a private hospital where you decide and you get it. But any government hospital takes huge effort from initiation of a project to completion of a project. So this is how we needed modern ophthalmology for combat effectiveness, reduced disability, faster rehabilitation, operational superiority, and enhanced morale. We decided to develop super specialty care at our tertiary care hospitals, which is at bigger centers, and equip all our smaller hospitals with the latest gadgets. These are the things which was kept in mind that we have to upgrade with the model ophthalmic OTs, dedicated retina and cornea suits, and daycare microsurgery complex in collaboration with the National Epics Institutes. So this was basically to reduce need for several referrals, faster surgical turnovers, and standardized equipments across the services. So this is how we started our journey. We started getting equipped from basic to the most modern equipment in the world. So we have OCTs, angiography, optical biometry. You can see these are the equipments. We started pouring in. Initially it took little time, but then it started pouring in. Then at one point of time, we decided, no, we have everything now. What else? What else? So we were searching for getting the latest, which was launched in the world, so to get this. So I've been very, very lucky that I was able to convince my superiors, the financial people especially, how difficult the financial people in a government setup can be, to convince them that why we need this. And this is how we started developing as an organization. We started holding more and more CMEs and workshop. We have started this new modality of, combining the Armed Forces International Ophthalmological Conference in collaboration with AIOS and DOS, a regular interval. This is basically, concept was created to give my younger specialists, those especially who are posted at periphery, to give them an opportunity to come to a national stage and present, because these are the people where voices were not heard. They were doing good work, but they could not present in our national platforms. So gave them a platform to present there. And I was so happy that they are doing now so wonderful job, and it makes us feel very proud. We have also, we were the first one to start this advanced simulator-based skills center. We put our residents, the residents who join us, these are the most advanced simulators. We have procured 3 of them at each center. That is one in Delhi, one in Bangalore, and one at Pune. Then latest equipments and exposure to fellowship. Fellowship we have started. We have taken up a case. Now we'll start a fellowship in vitreoretina. And next year onwards, we will try to get MCH program in cornea also. Apart from that, we'll also start the PhD programs. So these are the things. If you see this, it's, for me, it'll take a lot of time for me to tell what are the equipments we have been able to procure. One thing which we have, actually we feel very proud that with the help of Madam and Dr. Tanuj Dada, we have been able to do MIGS, we have taken to a new level. With the acquisition of flex angiography machine, we are doing a lot of novel projects which has not been done earlier. And that's one thing which is very, very close to our heart. And we want to, and we will take it to a new height in next coming 1 year or so. In cornea, we have been doing a wonderful job in keratoplasties. We have all centers. We have got femto laser in almost 7-8 centers. So we have wonderful team of young cornea specialists who are doing wonderful jobs. And we have had, in last 1 year, we have had 4 case and 1 original article accepted in Journal of Eye, which makes us feel very proud. We are doing a wonderful job in ocular trauma, because we are an Apex trauma center. We have got all cases, referred cases to us with almost end-stage trauma. So we have tried to salvage, and we've been successful in salvaging so many eyes. One thing which is very, very heartening is that we have a very developed ROP services. We have young specialists, retina specialist Ashutosh is there. So they're doing a lot of ROPs. We have a very active ROP screening and surgical program. We are able to take up to stage 4B. We have advanced strabismus and other uvea centers also. We have been able to procure smile machines and a femtoLASIK to almost all our advanced centers. So this is a cataract suit markerless. These are the centers which have been able to, so this is idea, basically it's not just that Apex Center of RNR has got this equipment. This is available at all our hospitals, of command hospital level hospitals. So this is IOCT. Again, these are the centers who have got this IOCTs. The Spectralis machine, these are the centers we have got. Cirrus we have been able to give to all 42 centers topography. The iStar, we were the first government set up in the country to get this iStar from Hawk Street. We have multiple IOL power calculation machine with Tormi and IOL Master 700 in all command hospital level hospitals. So we have a very high advanced dry eye management system. Specular, we have given to all those centers who have got eye banks. We have just this machine, finished 10 years down the line. We are now going to procure the latest model of specular microscope. We have this ultra wide field Optos. We've given to 10 centers, and 4 more centers are going to get this Optos in next 6 months. iTrace, 10 centers. 4 more centers are likely to be equipped in next 3 months. These are we have taken a lead in animaloscope. These are the one with a latest model animaloscope in all these centers, because we also do medicals for the troops. ERG machine is there. Pascal lasers we've been able to get to all our command hospitals. Humphrey, this is just the few hospitals, but we've just procured Humphrey in 46 centers, ma'am, at one go in 46 centers. All our centers right down to Dimapur has got the latest Humphrey machine now. And it's very difficult, ma'am, you know that how as a singer, you want Humphrey only, you keep saying, and the financial people say कि नहीं हम नहीं दे सकते because it is single vendor. So I fought, मैं कहा single vendor ही चाहिए मुझे. So he says अच्छा ठीक है चाहिए तो ले लो आप. So they were very, this is the simulator which I was talking about. These are the machines, FACO machines we are replacing now. Infinity is now gone, so we are replacing Infinity with Centurion Silver in next 56 centers. We were the first one to get Veritas in 56 centers. The Veritas launched with armed forces only. They gave us 50, and they ran out of their machines after that. So these are the flax machine. We're the first center in the government setup to get flax, the modular flax, the portable flax, the Lensar machine. These are the 3D microscope. We have 14 centers with 3D microscope, the latest from the Carl Zeiss machine. Aqueous angiography, we have 2 centers. We are doing a very, very high volume of aqueous angiography, and we are coming up with multiple RCTs in that. So these are the ROP stages. So from pinnacle to periphery. This is one thing which is separately. This was the modernization part, and this is now the outreach program. We have started in a big manner, the outreach program, and we have done 7 super specialty camps. It's like a concept of a flying hospital. We were labeled as a flying hospital. So this is a chartered aircraft from the Air Force, the most advanced C-295 Airbus, which is from Spain. So we send our all latest equipments from Delhi to the centers, even like in Lakshadweep. We went to Lakshadweep. It was a very difficult task to reach to Lakshadweep with all our equipments. We reached Lakshadweep. We went to JNK. We operated so many civilians who were displaced during Operation Sindhu. So it was, they felt very high gratitude to armed forces that, giving them, and all these super specialized care was given free of cost, including lenses, which are imported lenses, and Centurion gold machine operating. We also did multiple cases of MIGS surgeries and anti-VEGF, free of cost to this. So we have done 7 till date. Now we are going to a place in Leh, which is a very challenging situation. Then from Leh, we will go to Srinagar. Then from Srinagar, we will go to Itanagar. So we have done multiple, patients, civilian patients from Nepal, which actually made a lot of headlines in Nepal that, the friendship was, it added to the friendship between India and Nepal. So these are the various anti-VEGFs which is available to all the small centers, because we have worked very hard to put it in the DG rate contract. So that means even a specialist, just trained can get this. We are giving everything free of cost to our clientele. These are the latest IOL we have in the rate contract. You can see this. These are the LASIK suits we have for the 7 centers. And this eye bank, where the eye bank is, where the cornea specialist is the eye bank. We started this indigenous plaque brachytherapy for ocular tumors. We're very proud to be joint collaboration with RP Center. Madam was there. We have joined, we have got these pilot projects, which is basically diagnosis of diabetic retinopathy. We will do a multiple outreach programs, and in next 1 year, we will be having a huge data in a collaborative study with RP Center. We have also started this joint CME with RP Center, that one will be at RP Center, one will be at RNR. So basically in the pipeline, we have now automated microperimetry, pentacam Corvis ST, and digital slit lamp. This digital slit lamp is very close to my heart because we want to upgrade, and this LRA model, which has been just launched in India, we are going to procure 126 of them. So this is now the new center, which is we are getting up at Army Hospital RNR. It's a 5-storied standalone center. I say a replica of RP Center, but yes, we have a vision for future, and it is going to be inaugurated in 2027. Thank you so much. This was a talk from my heart, and I thank my complete team. It is not possible to work alone. My team has been simply outstanding, and this talk is dedicated for them only. Thank you so much.
Thank you everybody for attending this session. With that, we conclude the session. We have 2 speakers who were not able to come. But apart from that, we've had a wonderful galaxy of speakers, and thank you everybody. I also like to thank the other moderators and members of the scientific committee for having arranged the session and staying throughout. Thank you.